Hello, and thank you for coming to day 2 of our workshop, an NIH-sponsored workshop on non-pharmacological approaches to the early prevention of ADRD. Those of you who were here yesterday realized that we had quite an elaborate, lively set of presentations and questions and answers. There were over 160 of you at one point who were here in the virtual space. Today we're continuing where we left off, and I'd just like to point out for those of you who weren't here yesterday that the way that this is being handled is that the session moderators will be introducing speakers for the individual sessions. Speakers will speak for up to 20 minutes, and then the bulk of the questions will be answered in the question and answer period following the session. Those of you who are in the virtual audience are welcome to send in questions. You should type them into the chat. They will then be relayed to the session moderators, in some cases compiled or consolidated if it's the same question that comes in, and we'll be dealing with it that way. So without further ado, I have nothing else more to say. Welcome on behalf of NIA. The next session is going to be session 3, entitled Issues in Intervention Development, How to Design the Most Informative Trials. And the moderator and chair for that session is actually Linda Collins, who is from New York University, who will be leading the thing and also delivering the talk on developing effective, affordable, scalable, efficient interventions. So Dr. Collins, all up to you.
Well, hello, everybody. As John said, I'm Linda Collins from New York University, and it's just an honor to be on this panel with two such amazing scientists, Melinda Power from George Washington University and Jason Doctor from the University of Southern California. I'm a little bit of an outsider here because I've never really done any research in aging. I've never had funding from NIA. My work has been in prevention. I've worked in the prevention field, but it's been more in the other end of the life course. I've done a lot of school-based drug abuse prevention and that sort of thing. So my interest here is probably a little more as a consumer of research on aging, being, like all of us, an aging person. And I was able to attend part of yesterday's session, and I have to say that I was so amazed at how casual everyone is about this. This just seems amazing to me. The prospect of developing an intervention that could prevent dementia, that just seems like a moonshot type goal, and it's just amazes me. And of course, this is something that if we do it, we want to do it right. And that's the kind of thing that we're going to be discussing in this session, is how to develop interventions that really have the potential to prevent dementia and have the kind of reach that we're looking for. I think that these are 3 nicely complementary presentations. Remember, I don't have to tell, I think, anyone in this audience, but public health impact is a function not only of the effectiveness of an intervention, but its reach as well. And that is evident, I think, in all 3 presentations. Melinda is going to be talking about the external validity of research. That's something that I think that we take for granted way too much, particularly in intervention science. Of course, if the interventions that are developed as part of this effort are to have reach and be able to prevent dementia in many people, they have to be based on widely generalizable research. So I think what Melinda is saying is really important. Jason is going to be talking about interventions within the healthcare system, for example, to change physician practice. There's just a huge potential for reach there. If you change one physician's practice, you change, of course, the outcome for all of the patients. And I'm going to be talking about a different way of thinking about intervention development and evaluation. And this approach I'm going to be talking about can be used to develop interventions with enhanced reach, if that's the objective. So I'm just really, really happy to be here. And I'm happy to start my talk now. If we could cue up my slides. Thank you. As I said, I'm going to be talking about developing effective, affordable, scalable, and efficient interventions. with the idea of maximizing public health reach. You can see my email address there. I hope we have a lively discussion today, and it's quite possible that we won't get to all of the questions. So if there's something that you have in mind and we don't get to your question, please feel free to email me. I'm going to be making 3 points today. The first one is that the classical treatment package approach, which I'm going to explain in a moment, is hindering progress in intervention development. The second point is that instead of using the classical treatment package approach, we could be achieving intervention ease by means of the multi-phase optimization strategy, or MOST. And my third point is that if we do this, we will accelerate progress toward prevention of ADRD in the long run. In the long run is really critical here. This is an illustration of the classical treatment package approach. You see that on the left, there's a number of components, and interventions are made up of a number of components. I'm not very familiar with interventions in aging, but in school-based drug abuse prevention, there might be as I was saying, in school-based drug abuse prevention, in a school-based drug abuse prevention intervention, there might be a component devoted to increasing resistance skills in kids. There might be a component that's a homework assignment that involves parents, and so on. The components are combined into an intervention that is represented by the black box there. And then that intervention is evaluated by means of an RCT. The RCT stands for, I think everyone in this audience knows this, randomized controlled trial, sometimes randomized clinical trial. And that's an experimental design in which typically there's one treatment group and one control group, although there may be more than one experimental, more than 2 experimental conditions. And the objective of this design is to directly compare the mean of the treatment condition to the mean of the control condition in order to establish whether the treatment performs better than the control. The RCT is a great way to assess the performance of the intervention as a package, but it does not tell us anything about individual intervention components. And that's something important to keep in mind as I continue. Now I'm going to critique the classical treatment package approach a little bit. And again, please keep in mind, I'm not critiquing the RCT, I'm critiquing the classical treatment package approach. This approach often produces interventions that are not affordable. And one reason is that in this approach, we first establish the efficacy of the treatment package, and only then we worry about whether the treatment package is affordable. But what if it isn't? What if it turns out that the treatment package is not affordable? Well, the only option at that point is to do some kind of ad hoc modification to the treatment package. That has to be done by removing one or more components from the intervention to make it affordable. The problem is that if the intervention was previously evaluated by means of an RCT, then you don't know which components are contributing to the overall effect and how much they're contributing. If you pull out one or more components, you might be pulling out components that are contributing hugely to the effect that you observed in the RCT, and that is a big problem. The classical treatment package approach also produces interventions that are not scalable. Again, the approach here is first establish the efficacy of the treatment package and only then worry about whether it's scalable. But there are a lot of reasons why interventions turn out not to be scalable. It might be too complicated. It might not be practical to implement in the intended setting. It might take too much staff time. It might be too burdensome for participants. There's lots and lots of reasons that can happen. Again, the only option to make an intervention scalable in the treatment package approach is an ad hoc modification. The same problem, you don't know which components should be removed. And the classical treatment package approach often produces inefficient interventions. And by inefficient, I mean interventions that have many components that are just not doing anything. We seem to have an unspoken agreement in intervention science that it's okay if an intervention includes lots of inert or counterproductive components, as long as the overall package has a significant effect in the RCT. Because that the overall package, treatment package, is the sole focus, many interventions, I would say, have intervention components that are doing nothing but taking up time and money. So to sum up, the consequences of this are that many interventions are too expensive or otherwise impractical, keeps them from being able to be implemented. Many interventions have then been subjected to ad hoc alterations. And those ad hoc alterations often undermine the effectiveness of the intervention, because once you start removing components, you don't know whether those components were important to the overall effect that you observed. And they likely include useless or possibly even counterproductive components. So is it any wonder that, and I'm quoting directly from an article by Onken et al., so many efficacious behavioral interventions do not make their way down the pipeline through implementation. And this is something I think we can all agree we hope does not happen to the interventions developed as a part of this initiative. And I want to point out that no other product is developed this way. No other product is developed using anything like the classical treatment package approach. And where would we be today if the classical approach had been used to develop the smartphone or modern automobiles or the laptop? We would be decades behind where we are now. And I believe that intervention development is decades behind where it could be. Instead, we could be achieving what I'll call intervention ease. I'm going to explain what that is by means of the multi-phase optimization strategy. Intervention ease is a strategic balance of effectiveness, affordability, scalability, and efficiency. I say it's a balance because you probably can achieve a more effective intervention if you don't worry about affordability, scalability, or efficiency, right? If you had all the money in the world to spend on an intervention and its implementation, you could probably develop a more effective intervention. But the fact is, we don't have all the money in the world, that there are always upper limits on affordability, scalability, and efficiency is always something that's important to strive for. So ease is achieved by balancing, on the one hand, effectiveness, on the other hand, affordability, scalability, and efficiency. And of course, the question is, how do you achieve that balance? I'm suggesting that we can achieve that balance through optimization. In developing the multi-phase optimization strategy, my collaborators and I have drawn on ideas from a number of fields, including engineering, where optimization is just completely woven into the fabric. Optimization is the process of identifying the strategic balance of effectiveness against affordability, scalability, and efficiency. The word optimize is used a lot colloquially. So I want to make the point here that optimization is not about finding the absolute best. You sometimes hear the word optimal used kind of as a synonym for best. But what we mean here is not the absolute best, but the best you can actually use. So the absolute best would be the most effective, but the optimized intervention is the most effective subject to realistic constraints on things like willingness to pay, available staff time, and so on. This is a schematic of the multi-phase optimization strategy. Now, I'm giving you, a very short outline in this talk of something that I do 5-day trainings in, so I don't expect that I'll be able to convey everything, but let's just take a quick look at this. There are 3 phases in most: preparation, optimization, and evaluation. In the preparation phase, the investigator lays the groundwork for optimization. Most of what's in here is stuff that you're familiar with already: deriving a conceptual model, identifying the set of candidate components. And I say candidate components because there's no guarantee that they're going to make it into the intervention. They're candidates for inclusion. You conduct pilot work here, and you would identify the optimization objective. The optimization objective is your definition of intervention ease. For example, your optimization objective might be the most effective intervention we can get for a cost of $200 a person. Next, the investigator, I'm sorry, can you go back? That was my mistake. Next, the investigator goes to the optimization phase, where the investigator builds the optimized intervention. And this is done by conducting one or more optimization trials. And those use designs other than the classical RCT. Might be a factorial experiment, a fractional factorial experiment, a SMART trial, a sequential multiple assignment randomized trial, micro-randomized trial. There's a number of different alternatives. And then once the experiment has been conducted, you use the results of the experiment to identify the set of components that meets the optimization objective that you identified in the preparation phase. The last phase is evaluation, in which the optimized intervention can be evaluated by means of an RCT. And there are these two fundamental principles across the top. You see the continual optimization principle, which says that much like in engineering, we're never satisfied. We can continue to improve an intervention over time. And the resource management principle says that the investigator selects the most efficient experimental design for the optimization trial. And some of you may be wondering, how can you possibly suggest that people would use a factorial experiment? There are a lot of misconceptions about factorial experiments out there, and I just want to say, and I only have time to assert this here, but when used to address suitable research questions, factorial experiments often require many fewer subjects than alternative designs. They can actually be extremely efficient. And if you don't believe me, you can take a look at any of those citations there. Okay, now I'd like to talk about how I believe that taking an approach like the multi-phase optimization strategy will accelerate progress toward prevention of AD, ADRD in the long run. Let's consider 10 years, 700 research participants. And we're going to pretend that we can kind of run, can you go back, please? We're going to pretend that we can run time in parallel. So there's a classical approach and then the most approach. So we're going to run the classical approach, turn back time, and run the most approach. So we have the classical treatment package approach versus optimization. So let's look at the classical approach in the box on the left. We have 10 years. Years 1 through 5, we're going to use 350 research participants. We'll do an RCT of an intervention composed of 5 components. The result, as sometimes happens, the intervention performs poorly. For the next 5 years, we're going to use the remaining research participants, do an RCT of an intervention composed of 5 new components. And the result is the intervention performs well, which is great. Now let's turn the clock back and take the multi-phase optimization strategy approach. In years 1 through 3, we're going to use 200 research subjects, and we're going to do an optimization trial of the same 5 components. Now remember, in an optimization trial, it's a different kind of experimental design where it enables estimation of the individual effects of the individual components and usually whether they interact. As a result, we find that 2 of those components perform well, 3 of them perform poorly. Now, the next few years, years 4 through 6, we're going to take another 200 participants. We're going to do an optimization trial of 5 new components, the same ones that were done in the second 5 years, same ones that were examined in the second 5 years of the classical approach. Result, 3 of those components perform well, 2 perform poorly. And in the remaining years, we're going to take 300 subjects and conduct an RCT of an intervention composed of the 5 good components. And at the same time, we're going to examine 4 new components. There's a hybrid experimental design that enables you to essentially conduct an RCT on an intervention and examine individual components at the same time. I can talk about that if you're interested. The result is that the new intervention performs well, 2 of the new components perform well, and 2 perform poorly. I just want to point out The classical approach, the classical scientists examined 5 components in the first 5 years, and those were examined by the scientists using most, who found that 2 performed well, 3 performed poorly. The second set of 5 components was examined by the scientists using most, who found that 3 performed well and 2 performed poorly. Now let's look at what has been accomplished after 10 years. In both cases, we developed a successful intervention composed of 5 components. With the classical approach, it's not known that only 3 of those 5 components are active. 2 of them are inert and doing nothing. And it's also unknown that 2 components from the first intervention could have been salvaged. The scientist who used most has developed a successful intervention composed of 5 components, but all 5 of those components are active. And over the course of 10 years, the scientist learned that out of 14 components tested, 7 worked and 7 didn't. Now, what are the immediate next steps to improve the intervention? In the classical approach, it's unclear what the immediate next steps are. And in fact, in the classical approach, there really is not much of an emphasis on continual improvement of an intervention over time. However, this is a critical feature of most, continual improvement of an intervention over time. In fact, I would love to see us have successive versions of interventions that are continually better in much the same way software is released. So the most scientist knows now that the next thing to do would be perhaps to add the 2 components that were found to be active in that 3rd experiment. The scientist also knows what the weak points of the intervention are, because the scientist knows which components that were tried out worked and which ones didn't. So another logical next step would be to develop and test some new components to replace those. Or the scientist would work toward an intervention that is about as effective but cheaper or shorter, or there's lots and lots and lots of other possibilities. I've tried to make 3 points today. The first one is that the classical treatment package approach is hindering progress. The second one is that instead we could be achieving intervention ease by the multi-phase optimization strategy, and that this will accelerate progress toward prevention of AD, ADRD in the long run. And the long run is really critical. The question I get sometimes is the following: is most feasible? Most is a very, very different way of conducting intervention research. It may seem strange to you if you had never heard of it before, and you may be wondering, is it feasible to conduct an optimization trial? Well, NIH has funded well over 100 grants that involve intervention optimization in one form or another. It's still a very small part of the overall intervention science budget, but it's certainly not an untried approach anymore. If you're interested in learning more, don't buy these books. I say that because you can download PDF versions for free, most likely from the Springer portal at your university library. So I hope I've gotten you interested today in the multi-phase optimization strategy. There's a lot to talk about. It's, as I said, it's a very different way of thinking. We couldn't cover everything today, but I hope I just gave you a sense of what it is and what it can do. Thank you.
Wonderful talk, Dr. Collins. You have 35 seconds left, so perhaps we should just get to the next talk
Sure.
in the session, but I know that this will generate a lot of interest in the question and answer.
Hi, I'm Melinda Power, and I'm an associate professor of epidemiology and director of the GW Institute for Brain Health and Dementia. I want to disclose funding from the National Institutes of Health, thank you, the Department of Defense, and DC Health. So what I'm going to tackle today is this question. Who do we really end up recruiting into our trials and into our research? And the corollary to that is, should we care who we're recruiting? And I hope by the end of this talk, you will agree with me that the answer is yes. So if we take a step back to first principles, there are 2 major study types that we usually use in biomedical research. They're observational studies and clinical trials. And if we think about the archetypal version of each of these studies, observational studies are typically recruited or designed to be representative of a defined population at baseline. Typically, you have to be a member of a community, a clinic, or a particular administrative unit, say an HMO or a health maintenance, or some sort of other health plan. Clinical trials, on the other hand, are typically a convenience sample, and they have a lot of inclusion and exclusion criteria reflecting ethical, safety, and feasibility concerns. So if we think about an example observational study, this is one I work with a lot, the ARIC study, or Atherosclerosis Risk and Community Study. It was an observational study of cardiovascular health that transitioned to be a study of aging and dementia. It was designed to be representative of community-dwelling adults from 4 US communities that are listed on the map. And really the only inclusion or exclusion criteria, aside from being a member of those communities, it was an age restriction. You had to be between ages 45 and 65 at enrollment. Another example of an observational study is the Health and Retirement Study, used a lot in cognitive aging research. It's designed to recruit and follow a US representative sample of adults aged 50 and older, and it's replenished with new enrollment approximately every 6 years to maintain the steady state cohort. So again, really the only inclusion or exclusion criteria is that you have to be a resident of the United States and you have to be over age 50. Now, if we contrast that with a clinical trial, this one is one that was recently fielded, SprintMind. It was an RCT of medicating to a systolic blood pressure target of 120 millimeters mercury versus 140 millimeters mercury on dementia as the primary outcome. The inclusion criteria included age restrictions, but also included things like systolic blood pressure between 130 and 180 millimeters mercury, increased cardiovascular risk, no history of dementia, stroke, or diabetes. And then there were a variety of other exclusion criteria reflecting safety, feasibility, and ethical concerns. So for example, SprintMind participants couldn't have an indication for a specific antihypertensive medication, right? It'd be unethical to withhold that. They couldn't have an arm circumference incompatible with an accurate blood pressure measurement. It's a feasibility concern. And then there were a variety of things like expected survival for less than 3 years, active alcohol abuse, lack of support from a primary health provider, or history of missed clinic visits that again go to feasibility. Are these people going to come back and actually participate and stay within the trial to the end? And what we end up with is a situation where the observational studies and the clinical trials are really just capturing completely different target populations. So what I have here on the left is the proportion of ARIC Visit 5 participants on the top, the proportion of HRS Wave 2006 to 2016 participants on the bottom, who would be eligible for inclusion in selected RCTs of antihypertensive medication use for the prevention of dementia or cognitive decline. And you can see here that relatively few people that we include in our typical observational studies would meet the major eligibility criteria for inclusion in these clinical trials. So the next question is, does this really matter, right? So we understand that clinical trials have a different population than your observational studies, but does it really matter? And so Con Giannatasio, who's pictured here, who's a member of my lab, set out to answer this question by comparing 2 samples with similar high quality cognitive, neuroimaging, and clinical data. We looked at the ADNI, Alzheimer's Disease Neuroimaging Initiative, which is a highly selected sample that's designed to emulate a clinical trial population. So even though it's an observational study, it has many of the same restrictions that a clinical trial would have. And then we'll contrast that with the Atherosclerosis Risk and Community Study, or ARIC, that I previously described. Again, a community-based sample designed to be representative at baseline. She did was she compared finding across data sets to assess whether findings from one would generalize to the other. The first step was to restrict both samples to Black and white participants over age 65. And then she identified variables that were available in both data sets that were essentially equivalent information. We then estimated adjusted exposure outcome associations between sociodemographics and health on cognitive test scores, sociodemographics and health on neuroimaging, and cognitive test scores on neuroimaging. And then look for evidence of differences by cohort. Would we get a different answer? And we'd look at that both statistically, based on statistical significance of interactions by sample, and quantitatively, the difference in magnitude of the point estimates. So if we look at the two samples, just off the bat, we can see again, these are very different samples. Although they have very similar age, you can see that ADNI is more likely to be male, much higher educated, less likely to be Black, and more likely to be married. Interestingly, they're also much more likely to have more than at least one ApoE4 allele. If you look at their cognitive outcomes, we start off, you're looking at MMSE scores. About the same percentage have an MMSE score of less than 25, indicating some sort of level of cognitive impairment. The MRI outcomes, again, are very similar across the two cohorts. But then if you go look down at cognitive status, that belies a very large difference in cognitive status as assessed clinically, whereas about only 40% of ADNI participants were considered cognitively normal versus over 70% of ERIC participants. So our findings here are that the proportion of associations that differ across ADNI and ERIC are substantial. So among all associations, about 34% differed statistically and 50% differed quantitatively. When we restricted that to associations that were statistically significant in at least one cohort, so that we weren't just comparing two results that were null no matter what, that went up to 50% in both cases. And you can see from the plot below, this is just one forest plot of the many associations that we considered. You can see that these differences are sometimes really meaningful in what you would conclude from the study. So for example, here you can see that in ERIC, we would not see an association between ApoE4 status and performance on the Boston naming test, whereas we do see a strong association in ADNI. On the other hand, we see a strong association in ADNI between imaging findings and Boston naming test, but a much less strong association in ERIC. So the conclusion here is that who is in your sample influences your findings, and results from highly selected populations may not generalize to more representative populations. So what you're finding in your clinical trials may not actually be applicable to the same degree in a broader sample. We also see that research samples lack sufficient representation of important subgroups to quantify subgroup effects, and this is really important. I want to use the example of race ethnicity here to highlight this. So historically, both observational studies and RCTs of aging and dementia have recruited samples that were predominantly non-Hispanic white. I do want to note that this is starting to change due to the efforts of a lot of people who've been working on this for a long time. But this is unfortunate because we do know the burden of disease and treatment efficacy may vary by race ethnicity. So there's emerging evidence of racial heterogeneity in drug responses to new molecular entities, as well as persistent racial disparities in risk. What I have here on our right is a plot of the prevalence ratio on the top and the hazard ratio on the bottom, showing Black-white racial disparities in dementia risk and how they persist over time. So for example, on the top, you can see that the prevalence ratio comparing Blacks to whites in 2000 is roughly equivalent to what we saw in 2006 or not 2016, and we're not seeing a lot of movement there. Same thing with 2000 to 2012. And in order to really make progress on these disparities, we need studies that have sufficient representations of these groups to really understand what's driving them. How we recruit and collect data also influences who we identify as having dementia. So if we think about dementia ascertainment methods, these typically include in-person or research-based assessment, which is considered the criterion standard. We could also use algorithms based on cognitive testing or other data, as well as administrative data sources, including death records, EMR, or Medicaid claims. So the question becomes, how much does the ascertainment method matter, and how much does it influence prevalence and risk factor associations? So to look at this, we used data from the ADAMS study, which is an HRS sub-study where they ascertained dementia status, and compared criterion standard dementia ascertainment to algorithms and Medicare claim dementia ascertainment in terms of what we would get for dementia prevalence as well as risk factor associations. And what we found was that sensitivity, specificity, and accuracy of all of these non-criterion standard options often vary substantially by participant characteristics relative to the criteria by participant characteristics. So what I've shown you here is a table that's just the performance metrics for Medicare claims compared to the ADAMS research classification by participant characteristics. So overall, we have a sensitivity of about 47%, specificity is relatively high at 98%, and accuracy at 91%. but that really masks dramatic differences by participant characteristics. So you can see it varies by age, by gender, by race, by whether someone has more or less than a high school education, and even by whether someone has diabetes or not. So what we conclude from this is that, if you're using these alternate classifications, you're going to miss almost half of the people living with dementia. And those missed people are not random. They're more likely to be young, male, Black, have lower educational attainment, have diabetes. And on the flip side, a substantial portion of persons identified as living with dementia aren't going to actually have it. And those cognitively normal individuals who are falsely classified are, again, not random. They're more likely to be older, male, have higher education, and have diabetes. So what is the implication for this? Well, first off, we found that use of different dementia ascertainments influences prevalence estimates. And that should be pretty obvious if you think through it, right? Your sensitivity and your specificity are going to influence what your ultimate prevalence estimate is going to be. But interestingly, use of different dementia ascertainment methods can also change the inference of your studies. So the individual meaning of these plots isn't terribly important. What I want you to notice is that for each of these plots, what we're plotting is a risk factor association between a participant characteristic and dementia. The black dots are the atoms or the criterion standard diagnoses, and then the blue, green, and yellow are different algorithms or Medicare. And what I want you to take away from this is that we're not recovering the black dot, right? We're not getting inference that always matches what we would get with the criterion standard. And how much we don't match matters both in terms of what the risk factor is and what the algorithm is. So if you think about this, recruitment decisions are also often measurement decisions, right? So we make trade-offs about who and how we recruit people, and that influences whether we can get those criterion standard diagnoses or whether we're going to be relying on alternate measures of cognition and cognitive health. And this is unfortunate because different dementia ascertainment approaches can yield different answers. So some of the heterogeneity that we're seeing in our studies are probably measurement issues as opposed to actual differences in findings. And finally, I want to note that recruitment processes are not the only determinant of who is in your sample. Loss to follow-up can lead to selection bias or lack of generalizability. So if we think about loss to follow-up, right, you recruit everyone into your sample, you try to follow them longitudinally over time. Typically for studies of cognition and aging, we're either studying people for a very long time or into old age. And in both cases, we tend to lose a lot of participants along the way, right? People get frail, people don't want to participate anymore, or people die and you can no longer follow them. Now, I want to note that loss to follow-up is a potential issue in both observational studies and clinical trials. So this is not, a sin of the observational studies alone, even though it's often overlooked in the context of a clinical trial. And persons who are lost to follow-up are often older, have more cognitive impairment, functional limitations, more health conditions, and more risk factors for poor health. So again, you're not losing a random selection of your participants. And this has implications, right? Your effect estimate may not generalize to those lost to follow-up. Those individuals, the association or the effect might actually be different. And if loss to follow-up is related to exposure and outcome, this also may introduce selection bias. So not only do you have to worry about generalizability, but your results could actually be internally invalid as well. Depending on your question, it is important to think that you may need to be concerned about selection bias from loss to follow-up due to both dropout and death. It really is a philosophical question in many ways, whether you're looking at etiology or you're looking at prediction. And what we see here on the right is an example of how this can impact our study findings. So this was a study by Rawlings et al. On the ERIC cohort that looked for the effect of accounting for selective attrition using a statistical method on the association between HbA1c and cognitive change. You can see that the unadjusted for attrition estimates are in gray and the adjusted for attrition estimates are in black. And the association here is between HbA1c and cognitive change gets much stronger for those diagnosed diabetes categories when you adjust for attrition. Now, this isn't ideal, right? We're adjusting for attrition, we're making all sorts of assumptions in order to do so, but these methods are arguably going to give us a better sense of what's really going on than naive analyses. So in conclusion, I want you to take away from this that who we recruit is often a function of study design, right? We're not going to be able to get rid of the ethical or safety considerations of an RCT, And we're probably not going to be changing, there's a lot of benefit to having our observational studies be representative. But who we recruit matters, right? Effects can differ across target populations. So trial results may not generalize to broader populations and vice versa. Next, recruitment decisions are also measurement decisions, and different dementia ascertainment approaches can yield different answers. And finally, loss to follow-up can lead to selection bias or poor generalizability. Now, what I don't want you to walk away from this talk is to say, oh, what can we do, right? How do we ever trust anything? But I do want you to think carefully about what are the sources of heterogeneity and findings across populations, and how can we make the observational data more relevant to the clinical trial situation and vice versa, right? How can we close that gap a little bit to make sure that what we're doing is worth doing? I want to take a moment to acknowledge the co-authors on the work that I presented today, as well as the funding underwriting of presented work. And thank you to the staff, investigators, and participants of ADAMS, ADNI, ERIC, and HRS. And I thank you for your time. And I'll put my email here in case there's anything to follow up afterwards.
Thank you, Dr. Power. There is 3 minutes left. So it's possible, Linda, do you have a question or see a question come up in the chat that you feel can be done in 3 minutes?
I didn't see a question come up in the chat. One question that was running through my mind is, so the adjustment that you showed at the end, Melinda, that was a missing data procedure that made that adjustment, is that right?
Yeah, so that one was an inverse probability weighting approach where you essentially weight up people who look like those who are lost to account for their disappearance. There are a number of different approaches. There was a paper that the Melodem Initiative put out a couple of years that kind of goes through them all if you're interested. There's a lot of different statistical approaches you can take to address this issue. They all require you to make some sort of assumption that the people you see are still in some way representative of the people you've lost.
Right, yeah, yeah, they all make the not missing it, they make the assumption that the missing at random assumption. But still though, if you apply a missing data procedure, it's always moving you in the right direction, even if you don't get rid of all the bias. What do you think? What do you think would happen if the field sort of took a stand and everyone started using modern missing data methods to make adjustments? I think it would improve things. What do you think?
I think that would be fantastic. I've used this a lot in my own work at this point, and sometimes it makes no difference, and sometimes it makes all the difference in the world. And it is not 100% predictable when it's going to make that difference.
Right.
So
exactly. That's why it's so important.
Exactly. But yes, I do think it's really important. We have the tools, we have the methods. They are getting easier and easier to implement in standard software. They take some thought, right? But so do the rest of our analyses, and I'd really love to see this more broadly used.
Yeah, no, I agree completely. And I think if you talked about how results can be different across different studies. I've always felt that if everyone used modern missing data procedures, that would not completely iron that out, but it would help a lot.
And we're only missing 30.
There aren't any questions in the chat. So at this
No,
point.
I know we'll have some by the break, and in the next 27 seconds, I guess we can introduce our next speaker, who I see is already here.
All right, John, are you ready for me to go?
I think looks like everything's reset. Yeah, we can go.
Okay, great. So I'm Jason Doctor, and I'm a professor at the School of Policy at USC, the Saul Price School of Policy. I'm going to talk to you today about conducting large trials in the healthcare system. And while we haven't done much work to detect and prevent dementia, I can talk about what can be done and some of the strengths and limitations of large trials in the healthcare system and what they look like. So I want to thank the NIA for funding this research going back all the way to 2010 with an RC4 and then more recently with an R21 and an R33 mechanism. Next, please. Okay, so what goes into a large healthcare trial. That'll be part of what I'll discuss, limitations and scopes of these trials, and then opportunities for dementia research. Next. So I think it's important for people to understand not to expect too much from a healthcare system trial. The US healthcare system is fragmented and it's difficult to do long-term follow-up with healthcare data. Each of the electronic health record systems is different, and that means that it requires a lot of effort to get them all on to the same format for data analysis. You may know that in the early 2000s, early to mid 2000s, there was this meaningful use effort, which is still going on, where a lot of federal resources were devoted to data integration and decision support within electronic health records. The idea was to develop a way for these clinical systems to talk to each other so that patients treated at one hospital could also get their information transferred to a second hospital, but also it was to develop the learning healthcare system. And if you work within electronic health record at a hospital or primary care clinic, that was all part of meaningful use, and there was a lot of money poured into development of these systems. However, for Alzheimer's disease and related dementias, there's some limitations there because long-term care was excluded from meaningful use. So those systems can be more difficult to work with. It's also important to keep in mind that there's good and bad data in the system. Data that have financial or legal uses takes precedence in the electronic health record. So order data tends to be good. What did a physician do? Did they order a drug? Did they order a test? Did they perform a procedure, that sort of thing, or did they order a procedure? And also diagnoses are good because those are billable. Other data, not so good, maybe poorly structured in the electronic health record. Patient-reported outcomes are rarely used, at least nationally, although there are exceptions. A lot of data that would go into patient notes or reports is difficult to get out and would not be useful for a trial. Next slide, please. So we conducted a large randomized trial that then became part of this effort to connect EHRs around the country called P-Scanner that was funded by PCORI, and so that randomized trials could be conducted. And this just shows the map of P-Scanner and all the sites. Next slide, please. And basically, you can click again, because this is one of those multiple slides. You can keep clicking. Okay, thank you. So what I was talking about in terms of harmonizing the data is that each system has a different electronic health record. In this case, Epic, Cerner, the VA, NextGen. And you have to get the data all into a common format. And then you can query the data on the back end, once you have it in a common format, and pull data out and be fairly confident that the data are all representing the same thing. You can think of this in terms of languages. It's like Epic speaks Japanese, Cerner speaks German, the VA speaks Italian. We're going to all put it into Esperanto and then be able to ask it questions. Next slide, please. So our research program has focused heavily on what are called behavioral insights from psychology and economics, also called behavioral economics. And I'll just run through very quickly some of the studies that we've done. Next slide. So we've tackled these behavioral insights as ways to improve healthcare in the system. And they fall into sort of 6 different categories: decision fatigue, which is that decision making gets worse with repeated decisions over the course of a day. Loss aversion, which is from prospect theory, that losses loom larger than gains, and this can be used to incent treatments. Public commitments, that commitments bind our future self to the desires of our present self, that our present self wants to fulfill. So if there are things that physicians want to do but are having difficult time doing, commitments can be a mechanism to help with that. And social norms that we look for others for how we should act. Justification is the idea that we want others to approve of our behavior. So if we have to justify it, we'll be more careful with how we prescribe or the types of treatments that we offer in general. And then lastly, this idea of availability, that the more easily we can call some scenario to mind, the more probable we'll find it to be. So if there's a problem with risk assessment, a risk appraisal on the part of the clinician, we might be able to address that with availability by making harms within the patient's practice more available to them. Next slide. Okay, so I mentioned decision fatigue, and I'll just show you a little bit of what we've done. Next slide. So one of our early studies just went inside the electronic health record. It wasn't really a trial, but it looked to see that if this idea of decision fatigue, which had been shown to happen in other areas, like in the legal system, happened in medicine. And we were able to identify that later in the day, physicians were more likely to prescribe antibiotics than earlier in the day. And that when they got a lunch break, it sort of reset their clock a little bit, and they prescribed more like they did earlier in the day, in the morning. And next slide. This was replicated in another EHR system, Athena Health, after our study, which showed that over the course of the number of appointments in a day, that physicians were more likely to prescribe antibiotics later in the day. And the basic idea was we were able to use this large healthcare data system to show something about the psychology of decision making, that as you exercise your decision muscle over the course of the day, it becomes more tired and it becomes more difficult to make good decisions. Next slide. Loss aversion. Okay, I mentioned that loss aversion comes from prospect theory, and that it's this idea that losses loom larger than gains. Next slide. So we conducted a couple of studies on use of loss aversion as an incentive for exercise in low-income populations. One study, which is going to come out in June in Behavioral Science and Policy, and which the graph shows here, was a 12-week exercise program for people recruited within the electronic health record system to participate because they were part of a disease management program. These are people with obesity, diabetes, etc., and had been referred to their doctor to exercise through a program within the healthcare system. And we used an incentive strategy that involves giving someone, it's based on this idea of extended warranties, which are very popular, but you give someone a lottery with a high chance of success, but a very small chance of not succeeding. And then you explain that if you come back in for more exercise, so you get that lottery ticket for coming in for exercise, come in for more exercise, you insure against losing the lottery. And this becomes a very cost-effective way to provide incentives, and we showed that it functioned much better than the control condition, which received that lottery, but then also received a fixed payment in the expected value of the insurance. So the cost of the two programs were the same. With regard to this is different flavor of a study than we've done before, because we did follow people long-term. I think we used the electronic health record to recruit people, and then we had to develop sort of assessment mechanisms within it to see when people showed up for the exercise program. So it wasn't entirely using natural EHR data. Next slide. Also, we've studied this idea of public commitment. I mentioned before that commitments bind the future self to desires that the present self would like to fulfill. Next slide. And we were interested in reducing inappropriate antibiotic prescribing in the clinic. And we conducted an experiment where we had clinicians identify if they thought that antibiotic prescribing was a problem, inappropriate antibiotic prescribing. And then we had them sign a letter to their patients indicating that they were committed to only prescribing antibiotics when they're necessary. We blew it up to the size of an exam room poster, and we placed it in exam rooms during cold and flu season. This was obviously pre-COVID. And we observed, we randomized exam rooms to have these posters or not, clustered by clinic. And then we observed whether antibiotic prescribing changed or not after the poster was presented. Next slide. And we observed almost a 20 percentage point reduction in inappropriate prescribing when these posters were present. And this study, again, it was clustered by clinic, but also each exam room had a poster or not. And in this particular organization, clinicians had their own exam room, although that may not be the case always. And this became part of a national effort by the CDC to reduce inappropriate prescribing using these commitment posters. And several states adopted this strategy. Next slide. Okay, Susan mentioned factorial designs, and we actually conducted, and that no one would ever conduct one, but we actually conducted one. So I'm going to describe that. We had 3 different interventions to reduce inappropriate prescribing. One was called alternative prescribing, and one was social norms, and the third was justifications. I described social norms and justifications before. And the alternative prescribing was not effective, so I'll just run you through what was effective. Basically, we look at others for how to act. Again, that's the idea of social norms, and justification is that we want others to approve of our behavior. Next slide. So we published this trial in 2016, and we did it with 247 enrolled clinicians in 47 clinics around the country. And we varied whether people got 1, 2, or 3 of these interventions within a factorial design. Next slide. You can click again. And one more time. So the social norms intervention involved monthly emails where you were identified as a top performer or not a top performer. And this was based on ordering of clinicians within the, by their inappropriate antibiotic prescribing rate. And top performers were those who were in the top 10%. And so we gave them a social identity label. You're a top performer. And we gave them these monthly emails. We explained to them that they could become a top performer if they tied with the top 10%. It didn't just include 10% of people. And by the end of the trial, 64% were top performers. So that was really good. Next slide. And the justification condition, when someone prescribed an antibiotic inappropriately, we said that it was fine for them to do so, but they had to justify why. And this was the social accountability intervention, whereby it might engender reputational concerns if they had an inadequate justification. And we found, again, that this intervention was also effective in reducing inappropriate prescribing. Next slide. Next slide. So this shows baseline intervention and post-intervention, and you can see that both interventions were effective, but that once we turned off the accountable justification screens, prescribing went back up, whereas the case for peer comparison or the social norm emails, prescribing did not go back up. One possibility is that people had to learn on their own through peer comparison how to perform better, whereas for accountable justification, they were always prompted by a screen, and when that screen was no longer available, they just went back to their old habits. Next slide. Okay, I'm going to really talk quickly about this because I'm running low on time. But I mentioned this idea of availability or making harms more apparent, closing the loops on bad outcomes between clinicians and their patients. Next slide. So we did an analysis where we went into the prescription drug monitoring database in collaboration with the medical examiner's office at San Diego County, identified people who had opioid deaths in their practice that they had prescribed opioids to, and then fed that information back to them in a randomized trial. Next slide. And we observed almost a 10% decrease in milligram morphine equivalent prescribing by simply providing information, non-judgmental information about a death in practice. Next slide. Okay, so I want to make sure I have 3 minutes here to discuss opportunities for dementia research. So let's move on to the next slide. Okay, there's been some treatment woes with respect to treatments for Alzheimer's disease. Next slide. Basically the past 30 years have been chasing the amyloid tau hypothesis, and that this idea that the accumulation of amyloid B and tau proteins in the brain is the cause of pathology. Next slide. Regrettably, this has resulted in 200 failed drug trials. These neural correlates have not led to a causal understanding of what's happening in the brain. The high drug failure rate is actually higher than cancer, 99.6% of failed drugs in this area. And we still face this really high global burden of disease. Next slide. Next slide. So there are some newer theories that create space for healthcare system interventions. I think one issue with the amyloid hypothesis is it's so biological that it doesn't actually explain how we would prevent dementia without the use of drugs, and those drugs have not performed well. And there are other theories, like the microglia theory that Alzheimer's disease relates to a problem with the garbage collection system in the brain. And there's some evidence that exercise may restore this regulatory capacity. We have direct evidence in animals. And the human evidence, we know that there's up to 5 years delay in dementia for midlife, people who exercise in midlife through the Order study. So human behavior may play a role in dementia onset. Next slide. There's also this role of toxins. So if our brains are sort of trying to collect garbage and responding to toxins, there are common medications linked to dementia, anticholinergics, benzodiazepines, and certainly encouraging judicious use of these medications may delay the onset of dementia. Next slide. Next slide. We also know that deprescribing antipsychotics can improve dementia symptoms, and that prescription of antipsychotics is a common clinical practice. So this is another area where we could change physician behavior and maybe improve the health of people with dementia. Next slide. There's also possibilities for detection, trying to get physicians to do comprehensive assessments for Alzheimer's disease, like the Medicare billing code. It's not widely used, it doesn't fit well in primary care workflow, and it could benefit from a health system improvement trial. Next slide. So in conclusion, our AD priorities perhaps should be around brain, with respect to healthcare system trials, brain health, detection, deprescribing, ways to reach patients and clinicians through the AHR, and clinical behavior change interventions relevant to these new priorities, with the possibility of using the healthcare system as a way to address these issues. And that's it. Thank you.
Thank you, Jason. And those are the 3 talks for the session. We did run to time. We could actually just take the break now as scheduled, a couple minutes early, and then come back for the discussion at 2:15. People are okay with that? Let's do it, 2:15. Thank you. All right, we're all back. Dr. Collins, do you have any questions to read from chat, or do you have for your own?
Yeah, I have a few questions. Jason, I wanted to ask you, this is kind of, oh, good, now I can see you now. I can see you. Jason, I wanted to ask you, so I've done a little work in smoking, and this is going to be relevant. There's some question about how healthcare systems feel about smoking cessation interventions, because they sort of don't want to pay for them, because they feel that the people they pay for aren't necessarily going to be in their plan later. So they're kind of saving people from lung cancer that that they wouldn't have to pay for anyway. Do you see what I mean? And is there what do you think about interventions to prevent Alzheimer's disease in healthcare systems? Is there do they feel the same way about that, or do you think they'd be more open to sinking some money into it?
I think in midlife, you would run into the same issue. I think it would be something that, it's something that the government actually has to pay a lot for because of Medicare and the states as well. So I think there'd have to be incentives, quality improvement incentives for doing certain things, prescribing judiciously, getting people to exercise, etc.
Yeah, so it's not something they're necessarily going to want to do without incentives.
Yeah. Well, would the increasing prevalence of Medicare Advantage help somewhat here? In other words, you want to keep people in the same system before 65 as after 65, because you could you could incentivize it that way, right? That the longer people stay, you would give them more.
I think so. Yeah, that would work.
That's interesting, because it does seem to be that a lot of the prevention strategies, that take you right up to age 65 or Medicare, if you were doing them in a healthcare system, if you could stay within that ACO or HMO or something, maybe that would help. Because it did look, one of the key advantages of some of those healthcare systems, at least you do have records, you do have things you can look at. I know the next section we'll hear a little bit more about what you can glean from that record flow. But it was really interesting, because it did seem as if you had some pretty good ideas for how to actually affect, for example, physician behavior to at least, if not prevent Alzheimer's disease, at least perhaps, disincentivize things that we believe to be poor practices, the deprescribing bit, the anticholinergic drugs situations and things like this that you really could get some purchase on. Do you have any notion of anyone who's been working on some of those things within healthcare systems, so we'd have an idea of how much you can move the needle?
Well, we're doing a little work on benzodiazepines, but that's sort of in progress. But I'm not familiar with others who've taken that head on. I think in Australia, they've done a lot of work with deprescribing antipsychotics, and they've done some really great work with how to get physicians on board with not using those drugs as often. But in the US, I think there's definitely room for that. And with regard to anticholinergics, I think it's open. No one is really working on that right now.
Melinda, I wanted to ask you, how do you think we could do a better job sampling? I feel like it's so important. And of course, any intervention that comes out of this effort, we're going to want it to be able to be applicable to everyone and to work for everyone. So that suggests that we really would need excellent sampling. How do you think we could handle that? I mean, it seems like we could do a better job sampling per se. We might be able to do a better job with statistical corrections. What do you think?
Yeah, so I think, if we're thinking about trial sampling, right? Trying to get that to be more general.
Yeah, that's mainly what I was thinking, yeah.
A lot of that work is happening in some ways, right? Our more modern trials have better racial ethnic diversity than they used to. And I think a lot of the tools that people have been using to make that happen, just start thinking in more dimensions, right? So, think about who are the people that we're not getting? Maybe there's some sort of education sampling strata, or maybe there's other dimensions of things that we want to focus on. The other thing that's exciting, that's kind of an emerging methodological area, is the idea of transporting estimates. So if you can make sure that you have sampled sufficiently so that you can get good subgroup estimates, we can use statistical manipulation to say, okay, well, if the composition of the sample were different, what would that look like in terms of the effect of the trial, right, or effect of the intervention? Now, that does require us to think carefully at the onset about who's getting into the trial in the first place, because if you don't have an estimate for a certain subgroup, you cannot then use that estimate to transport to a population that has more or less of that subgroup. And we're actually working on it the other direction too, thinking about, okay, well, let's take our observational studies and let's start analyzing them, use those restrictions, use these kind of transportability type algorithms, and see if we can't take the observational data and tell us about something we expect to see from the trial, right? So, maybe some of the disconnect we see in the Alzheimer's trials between the observational data and the trial is really a target population issue. So maybe if our observational studies can show that, we can then think about, okay, what are the populations and what are the target that we really need to be in this trial in order to see a benefit? So I think there's a lot of different things we can do, some on the trial side and also some on the observational study side.
There's another issue about sampling that I think is interesting, and I'd be really interested to hear your take on this. Intervention scientists often say that that the kind of people who show up for the trial are the most gung-ho types, and that once an intervention goes to scale, it can be hard to get sort of the population at large to do all the things that the trial subjects were willing to do. And so that's one reason why there can be a little bit of a cliff between efficacy and effectiveness.
Yeah, I think that goes back to your talk as well, right? Why are we designing our trials to be pie in the sky? Yes, I see the argument for it, right? Like, you need to show that it works. But also, if it works and we can't actually implement it, what's the point, right? So maybe thinking more pragmatically about what those trials look like isn't necessarily a bad route to go down. Now, with Alzheimer's disease specifically, I'd just be happy with a very definitive positive trial. Like, that would be great, right? So like, I don't want to sacrifice that to go to something that's more pragmatic, but I do think we need to think about, is this intervention something that we can actually implement? How would we make it feasible for a large swath of the population to use? Because if we can't, then we have to go back to the drawing board and think about, what do we need to change? And we're kind of back to square one.
Yeah. So there's I'm sorry.
No, go for it, Linda. I knew
I was
we were
going
about
to
to
say,
do.
yeah, okay. There's a question in the chat for me, so I will I'll address that one. The question is that the traditional NIH grant is for 5 years, although we do have some phase awards that can support intervention optimization activities. Can you share examples of existing or offer suggestions for new NIH models that successfully support the kind of work called for in the MOST model? Were there key components of those efforts that worked, and were there specific challenges? Yeah, so as I said before, there have been more than 100, and actually that's from an NIH reporter search I did more than a year ago. So I think there's well over 100 now projects, funded projects using MOST, and they use like every mechanism, Ks, Rs, Us, lots and lots of different mechanisms. But I have to say that, and I'm sorry to say this because I don't mean to sound ungrateful for the NIH funding I've gotten over the years, but the NIH funding model really doesn't fit, well, MOST doesn't fit the NIH funding model very well. Maybe that's a better way to put it. And there's a couple of reasons for that. Well, no, maybe there's one fundamental reason, which is that MOST is very much a discovery-based approach. So, which is kind of the way we've all been trained, right? You do an experiment, you assess the results, and then that's the basis for planning the next experiment. And that can be hard to fit into 5 years of funding. So here's one thing that would be really great to be able to do. It would be really great if you could write a proposal like this. First I'm going to conduct an optimization trial. And then based on the results, I might conduct another optimization trial if I don't get very many components that hit the first time, or if I get a lot of components that hit and I think I've got the raw material for a great intervention, then I'll do an RCT. But currently you can't really put a branching like that in a grant proposal. And it would be really great if you could, maybe that's not the way to do it, but something like that, some more nimble way of enabling the investigator to, conduct a study of some kind. It's, in my case, in the most cases, would be an experiment, an optimization trial, and then based on the results of the optimization trial, decide what the next step is. That whatever the funding mechanism is, if it would enable that, that would be really great. Currently, when people want to write an RCT, the number one question I get is, should I propose just to do the optimization trial, or should I propose the optimization trial followed by an RCT? Now, there's a lot of factors that go into that, and I won't review them all here, but there's a big issue there because most reviewers would want you to include an RCT, because for a lot of reviewers, the RCT is the main event, and anything that leads up to that is just, just kind of messing around. That everything is leading up to an RCT, which is a perspective I don't agree with at all, because I think optimization trials make major contributions to science just in a different way. But here's the problem there. Suppose you conduct the optimization trial and none of the components are successful. None of the components have detectable effects. Then what? You propose to do an RCT, you can't really. So I usually recommend to people, don't propose that for that very reason. But then reviewers will say, well, there's no RCT here. What are you doing? So I think a number of things have to change, including reviewer perspectives on what contributes to science. Once reviewers are on board with the idea that optimization trials contribute to science too, I think that will help. So that's kind of a long answer, and I will shut up now. But that's obviously something that I could talk about for a long time, because I get a lot of questions about that, and I have to say there's a lot of frustration out there among scientists who are using MOST about exactly how to be proposing, writing proposals to get funding for their work. And there's not, sometimes it's obvious what to do. Other times there aren't very good answers.
So yeah, that is a problem. So we do have phased awards of various kinds where you do an R21, R61 first, and then, but the problem is as you point out, they don't sort of lend themselves to iterating on the optimization piece. So if the first phase only finds you part of what you need to know, it might be very obvious to do another round of that and before you do anything else. But the way that for example, an R21 or R33 is written, the R21 might actually allow you to do a reasonable or not, most kind of thing. But then if you weren't ready for a full RCT, then it would be difficult. And it'd be difficult even in administrative review to say, well, but now she's saying she's going to do something else rather than the original aims, and then everyone gets all weird about it. It's a problem, and you can imagine ways out of it, but it's definitely going to require some change in thinking. So one possibility that sometimes occurs is that if you provided infrastructure that would be able to, for example, run or add arms, to some kind of factorial trial. In other words, okay, fine, we'll have people come in for their treatment arms and then put them in a factorial design or something like that. And we provide the infrastructure to run the trial. That could get around some of it, but maybe not, because that wouldn't be seen as being like a full R01 or a full thing, right? Is that the other side of it?
Yeah, I'm not sure. You're probably right. I mean, the basic idea here is that in my talk you saw how I laid out most in one column and the classical treatment package approach in the other column, and the column on most was all sort of predicated on discovery. There was a 10-year period, and the most scientists did some stuff, and then based on that decided on what the next thing was to do, which maybe was cheating for me to put it that way, because that's not really possible now. But I was trying to illustrate that I really believe we could make more progress if scientists operated the way we were trained, that's how we were all trained to operate. That iterative discovery approach is how we were all trained.
And I had one question for Melinda, actually. So when I first saw it, and I got to see it before, you know, it was even prime time, the who and Eric could get into the various trials thing, and you find out that fewer than 10% across the board. One of the big concerns that was, at first I said, oh, this is so bad, you know, I just should stop doing what I'm doing. But then I realized it was a little bit more predictable than that, because most of the trials want people who are at a sweet spot of risk, right? Who aren't full blown with whatever disease you're trying to affect or prevent, and who aren't, however, so squeaky clean and safe that, you know, I could intervene on you all day, not show anything.
Mhm.
So there's that risk window that you have on the one hand, but then there's also that, will they stay in the trial window? On the other hand, who can I maintain in this trial? They tend to, you know, select for people who have stable study partners and who, you know, are high SCS and all that kind of stuff. And so, you know, even if you're trying to well, if the way to get into a trial is either to be at a sweet spot of risk or to be like a really highly conscientious trial participant, those are possibly not correlated with each other at all. They may even be anti-correlated. And so then when you looked at sort of the ADNI versus Eric, you know, findings and associations, it seemed to lead exactly to that. You're either in because of this or because of that. And of course, that's going to change completely the direction of the association. Is that your sense of what could be happening in some of these things, or am I thinking about this wrong?
That really comes to play. So the numbers I told you were just the major kind of inclusion criteria, because I didn't have a lot of data to get who's got the social support to stay in the trial, or, you know, who the physician's judgment. But yeah, so the difference is not that it's bad necessarily that they're not overlapping, but that we should recognize that they don't overlap because of this narrow band of needing to have risk factors to justify giving an intervention in the first place, and not having, you know, contraindications for treatment, things of that nature. And then when you get to ADNI versus Eric, we tried to kind of eliminate a lot of those things, and you're left with those two last answers, right? You still have people who are at higher risk, and you saw that with ApoE, right? And then you also saw people who were more motivated, right? People who are in ADNI got to a tertiary care center. They are more likely to be married, to have that social support. They are more likely to be highly educated. They tend to be those, be health seeking, right? Or have some sort of unusual symptoms. And so there's unmeasured differences there that I think also drive a lot of the things that we're seeing.
Okay. Well.
Yeah, and you know, it goes back to the question of should our interventions be targeted to that group, or should they be made such that they can be accomplished more widely?
Well, in prevention, I think one of the, at least in prevention, the other part of the life course, the more toward the beginning that I've been a part of, it seems like there is, when preventive interventions go to scale, there's this idea that they won't hurt the people that would never take up drug use no matter what. And there's a lot of kids who would never ever take up drug use no matter what. And then there is a proportion of them who are at least at risk for doing that, and the intervention will help them. So when we talk about who to admit into a study, that's really more a methodological or statistical question, maybe a statistical power question, so that we have a chance to show results, rather than it's something about how we're going to implement the intervention when the time comes for it to go to scale.
Good idea. It is 2:35, and this has been great, but the next thing is going to be great as well, and that'd be panel 4, non-intervention development. And here we have the chair, who is Dr. Maria Gleamore from UC San Francisco, and her speakers, who I think she can introduce.
Thank you. It's really a pleasure to get to introduce this lineup. Just briefly, I'll introduce our speakers and kind of the motivation for this panel. The previous presenters have really laid out the challenges and the opportunities to develop early prevention interventions. And I love the prior panel focusing on how to best design randomization-based approaches. But I think even in the really best of settings, RCTs are going to have important limitations regarding the flexibility of the intervention that can be evaluated. So even with most, what you randomize is what you learn about. And if you can't randomize it, it's very hard to learn about it. The length of time that we have to wait for convincing results, even with the acceleration of most, we're still waiting for a little while, and the lack of generalizability to different people and to different settings. And this last, I think, is a really important implicit limit challenge that is likely to be even more important for non-pharma interventions than for many of the pharma interventions. We have a lot of evidence now that for behavioral and psychosocial interventions, the settings are likely to be critically important as modifiers because they will really constrain behavioral responses to interventions. And it's not just sort of optimism, but I think it's at this point totally unrealistic to think that the same, say, exercise or dietary intervention or even psychological intervention would have similar results on individuals, regardless of factors such as socioeconomic position, exposure to interpersonal or structural racism, cultural and community resources and identity, or social network structures and connections. There, of course, is really a growing body of literature about the importance of those contextual factors. So when we think about some of Jen Manley's work, some of her trainees, Miguel Arce, Justina Avila-Riga, some of the work from Paula Gilsans at Kaiser, these things really suggest that context is an incredibly important factor and modifier of the influence of subsequent exposures. So when we're considering non-pharma interventions, we just have to consider context, and that means we are going to have to rely on observational studies to some extent. And there's a real burden on observational researchers. It's our job to do the best we can for identifying causal effects, in part so we can guide the people who are trying to develop interventions, so we can provide useful information to people who are developing interventions. And the other kind of implicit goal with observational research is that we provide the best available evidence in the absence of conclusive findings. So that's a really high challenge. And I think that observational health research has been dominated by a particular and I think unnecessarily narrow set of tools. And the challenges related to dementia and Alzheimer's research are particularly mismatched with the tools that we consider standard in observational epidemiology. So Dr. Sonia Swanson, who's going to be our first presenter, is going to present about best practices for approaches that are in some ways closely adjacent to contemporary tools, but have a really rigorous causal framework that has a big advantage in the sense of being more likely to actually identify causal effects that would actually be preventive instead of simply predictive. After Dr. Swanson, Dr. Emilie Courtin will, Emily, you're going to have to pronounce your name correctly. Everybody who knows my incapacity with languages can giggle at my mispronunciation, but she will present on quasi-experimental approaches. And quasi-experimental approaches are really not used a lot in epidemiology, but actually very valuable and common in other disciplines, such as economics. And they have a big advantage because often the quasi-experiment is something that has actually already been implemented, so we know it's implementable. So it's really directly applicable. For both of these approaches, both the sort of new user simulated trial designs that Dr. Swanson will talk about and the quasi-experiments that Dr. Courtin will talk about, sample size and diversity of the data source is a critical challenge. And when we think about adopting these methods, we are going to need large, diverse, long-term data sources. That's really going to be key to being able to use these tools. So Dr. Rachel Whitmer is going to talk about using data from healthcare administrative sources for observational studies. She's been doing some of the most just really innovative work to give us a life course perspective on when we should be trying to intervene. And finally, I think one of the funny challenges in our field is, although we all know intellectually we need to integrate evidence from multiple sources, in fact, that often is this sort of siloed, and we don't do that kind of evidence integration, and we don't have great rigorous tools to do evidence integration. Dr. Julie Zisimopoulos will review an approach that they are taking, which is pretty amazing because it really moves from the biological thinking to help guide hypothesis generation to rigorous observational work, and then moving into simulation, even into simulation-based projections, which can help provide the best possible evidence about particular policy or intervention decisions. So I think I'm really excited about this lineup. That was sort of a long intro, but I wanted to give a context of why we think this panel is terrific. So with that, I will hand it off to Dr. Swanson for her to start our presentation.
All right. All right, thank you so much for that great introduction, and thank you so much for inviting me to be part of this panel. I'm thrilled to present a few ideas on causal inference from observational data, again, in the context of Alzheimer's disease and related research. So next slide, please. So I want to start by sort of addressing how I'm going to frame this talk in juxtaposition to the traditional or more historic view of where we get our answers to causal questions. So if we have some sort of causal question, if we're trying to understand if a particular intervention might prevent dementia, for example, our go-to option is to design and conduct a randomized experiment to answer that. And of course, this is predicated on it being feasible, ethical, and timely. So if we think about early or midlife interventions in dementia research, we already see that the timeliness factor here is going to be a problem, that we'd have to wait decades for some sort of evidence to answer such a question. And so we're stuck with our decision-making being informed without that empirical evidence if we're insisting on waiting for it. So before I get to option two, I want to contrast sort of how this is viewed in the traditional way of thinking about medical research. So if you go to the next slide, please. This is a flowchart from a paper published in the 1980s that tries to illustrate how one should go about reading clinical journals. And so if you click first one time, you'll see that in this flowchart, one of the questions is what the intention of the study is. Was it to try to study a causal effect by distinguishing useful from useless or even harmful therapy? And so if that's the intention, then if you click again, the next question is, were patients randomly assigned? And if you answer to that the answer is no, then if you click again, this flowchart instructs you to just go on to the next article, to completely cease reading. And so I want to talk about how that's throwing away data, and that's throwing away our chance to try to empirically inform answers to our causal questions. So if you go to the next slide, really what the rest of my talk is about is saying that we have this option too, which is that we can carefully design and conduct an observational study that tries to emulate as best as we can the ideal randomized experiment, and that we should do so judiciously, we should do so transparently, and we should be aware of where our emulation is not perfect. I do want to just acknowledge that by observational data, I really mean any kind of data source, both found or strategically collected, that is not part of a randomized trial. And I think some of the talks coming after me are going to talk about particular kinds of data sources, but I'm talking very big picture here. So next slide, please. So in thinking about how one would go about emulating a target trial with observational data, there's essentially just two big steps that we're thinking through. And the first step is really just to try to articulate what is the protocol of the hypothetical randomized trial that we wish we could have conducted. What is the protocol of that target trial? And so we need to think through the same protocol elements that we would if we were trying to actually conduct that target trial. So think through the eligibility criteria being potentially adults around a certain age range, really specifying what the treatment strategies are and when they're provided and for how long they're provided. Of course, in our ideal, the assignment procedure would be random assignment, and then we'd be following participants for long periods of time to measure clinical outcomes, including potentially diagnosis. Now, one thing I also want to highlight when thinking about the protocol of this target trial is that if we're thinking about this ideal trial that has decades of follow-up, we'd also want to make sure to not just focus on the intention to treat effect or the effect of initiating the interventions, but also thinking about other questions, including potentially the effect of adhering to the assigned strategies, adhering to the interventions for the entire duration of follow-up. So if you go to the next slide, please. Then the next step after we've specified what the target trial protocol elements look like is just to think through really clearly how we would emulate them given our observational data. And I have a couple different types of core questions listed on the slide here, but they're essentially all versions of saying, did we measure things in a rich enough way and with sufficient frequency to really emulate each of these protocol elements? Can we really align and measure the eligibility criteria we're interested in? Can we actually assess the treatment strategies that we're interested in? When we get to thinking about emulating randomization, we have to think about whether we measured confounding sufficiently, and then whether we have an observed or observable follow-up period with appropriate measures of our outcome. And so again, we're thinking through all of those different kinds of questions when we're trying to analyze our observational data. Next slide, please. So one of the core things I want to emphasize here is that the process of specifying the target trial has to be a conversation, and it has to be a team effort that brings a lot of different types of expertise to the table. You really need epidemiologic or methodologic expertise to understand the feasibility of emulating a particular target trial given a particular data set, and know how you're going to try to tie the research question plus some assumptions and the data to answering that question in a valid way. You need substantive expertise to weigh the plausibility of the assumptions underlying how you make that bridge. And you need data-specific expertise to just frankly understand whether you're measuring what you think you're measuring in that particular setting, whether you really understand the data generating mechanisms underlying your data. But all of that just helps you understand the feasibility of emulating a particular trial. I'd say that in addition to that, the conversation has to include end users and stakeholders to ensure that you're actually emulating a target trial that you think is informative, that is actually answering meaningful questions in the end. The other thing I want to emphasize here is that given a particular data source, the target trial that you end up emulating might still be a compromise, but this is actually a feature and not a bug of thinking about our observational data analyses this way, because it helps us really contextualize where those compromises are and being really transparent about this when we're weighing the totality of information we're getting across many different types of data. Next slide. So in the next several slides, I want to just go through particular protocol elements and some of the challenges and opportunities that I see when we're using observational data to try to emulate that particular protocol element. And I want to start with eligibility, which actually Dr. Power really emphasized in the previous session very nicely, some of the core points I wanted to make here. So first, I would say observational data often allows us to be more agile in recruiting or finding more diverse populations. And so when we're really thinking about the implementation of our research, I think that this is really a huge benefit of observational data. This then also allows us to start studying heterogeneity across subgroups. We can find subgroups who would benefit the most, or also subgroups that might be harmed, and therefore we wouldn't want to give the intervention towards. We can contextualize disparities better, and then it gives us the framework for trying to address inequities as well. I would say, though, that we have to be aware of blind spots in our observational data. Certainly, there are still disparities in study participation or who exists in an available data set, and we just need to be mindful of that. And then it's not always going to be easy to measure relevant eligibility criteria in all data types. And so just to give an example of this last point, if we think about a target trial where we wanted to study something relatively later in life, and we wanted to exclude participants that had prodromal symptoms of dementia, the measurements of those prodromal symptoms might not be apparent in some of the data sources that we work with observational data, even though if you were truly doing that as a randomized trial, you would have a screening mechanism for those symptoms. And so again, I just raise this as a point of being aware of the blind spots in a given data set. Next slide. So another challenge, but also opportunity, is thinking about the treatment arms that we could study in observational data. So in a trial, it's often infeasible for us to really substantially increase the number of treatment arms that we want to study. Certainly just in terms of the cost, as well as having sufficient power to study lots of different treatment arms, this can become quite cumbersome. But in observational data, there's often situations that we can efficiently study multiple related or joint interventions. And I'd also say that it gives us a little bit of an opportunity to do something like progressively refine the interventions of interest over time too. And so just to give one example of thinking about this, on the screen here, I have a table showing several different interventions that we studied in the Rotterdam study data. So this is a cohort of several thousand participants followed for now over 30 years. And in this cohort study, we essentially proposed different interventions for lowering blood pressure, either below a target value or lowering it by a certain amount if hypertensive. We then also thought about combining these interventions with having those who were smoking at baseline to also quit smoking. And again, this just shows that we were able to kind of look at the whole spectrum of these different types of interventions all in one study, rather than having 10 arms to a randomized trial. Next slide. So, of course, the biggest challenge to think about is randomization. In a trial, the randomization that we have for how we assign treatment strategies is the reason why we expect individuals following different interventions to be comparable at baseline. Again, this is like the golden reason why we're doing trials in the first place. In observational data, on the other hand, we can only hope to emulate this. We can either do so by assuming that we have random assignment within levels of measured covariates. And so this is, again, thinking about adjusting for measured confounding. Or we can do so by finding a natural source of variation, and that's really going to be the topic of the next presentation. So this is really the fundamental difference between observational data and trials. And I think we just need to embrace that this difference, of course, is there, but that we therefore need to do our best to always try to falsify the assumptions underlying our analyses, and to try as many sensitivity analyses as appropriate to really understand how sensitive our study conclusions are to the underlying assumptions, and in particular, plausible violations of those assumptions. And so I'm going to give a couple of examples of that going forward, but I just want to say that there's a huge literature on how to do that. There's some disciplines that certainly have embraced this as the norm, but I think that it isn't demanded enough in standard medical literature yet to really use all of these different strategies each time. Next slide. So these pieces together get me to the point of thinking about time zero and what that means in a trial, and in contrast to thinking about that of how we emulate it in an observational data analysis. So in a trial, 3 events co-occur at time zero. The treatment is assigned, eligibility criteria are applied, and outcome recording begins. And so when emulating a trial, as best as we can, we should choose to apply these 3 events concurrently. Next slide. In practice, though, these 3 events may not always be concurrent. And so just to give one example of this, if we were trying to study the effects of educational attainment or years of schooling on later dementia risk, you could think of the treatment assignment as happening in early adulthood, but often we're using data where that's retrospectively reported among older adults. And so we're implicitly applying eligibility criteria of at least living up to a certain age and maybe maybe also being dementia-free as of the beginning of that follow-up period. Next slide. So if you have this kind of unclear or misspecified time zero, you can open yourself up to similar selection biases as what would occur if you conditioned on post-randomization events in a trial. I want to point out that this is often a self-inflicted bias, and that actually thinking about emulating target trials helps you think through how to analyze observational data in a way that you could avoid having this bias in the first place. And so when you can, of course, the recommendation is simply to avoid this bias by just aligning the elements of time zero. But in some settings, it might be unavoidable because the eligibility criteria maybe aren't measured frequently enough, for example. And so in that case, then we have to use best practices to mitigate this bias that we can again borrow from some of what's been learned in the trial literature. Next slide. So I think it's important to step back and contextualize the shared challenges between observational studies and trials, because I think that there's a lot of things, and Dr. Power actually alluded to this earlier, that get assigned sort of to how we think about observational data limitations that also are apparent in the ideal trials that would answer the same questions. And so when we're clear about what the shared challenges are, it really informs best practices in both types of studies. It helps us interpret and compare the results. So if we're trying to make sense of results from both trials and observational data side by side. And then it also helps drive methodologic development. And so I want to think about two kind of broader categories of challenges that I see that are shared between observational studies and trials. The first challenge is making sure that we stay focused on patient-centered or population-centered effects. And there's lots of different ways to think about this, but really it comes down to making sure that we're actually asking meaningful questions. So one example of this is that focus groups that I've been a part of for qualitative research, asking patients what they prefer, have really shown that absolute risks are more interpretable and more informative for them facing decisions. And again, there's also epidemiologic and other methods support of focusing on absolute risks as opposed to, say, hazards ratios or other relative risks. Another area of making sure that we have really actionable questions is thinking carefully about how we're going to deal with the competing event of death when we're analyzing long-term outcomes and having long follow-up periods. And I think there's really emerging literature in the causal inference field on how to ensure that these questions are actionable. I don't have time to get into the details, but I just want to emphasize that Jessica Young and others have been really at the forefront of trying to push getting these questions clarified and getting the analytic approaches aligned with them. So that gets us to the second big challenge that is shared, which is that if we're really looking at sustained interventions with really lengthy follow-up, this increases the inevitability of non-adherence, of loss to follow-up, and then again of deaths as competing or truncation events. And so another way to think about this is that as soon as we're studying something with a long follow-up, a randomized trial with that long follow-up starts to look a lot like an observational study. And recognizing this again, I think helps inform best practices across both how we conduct and analyze randomized trials and observational studies, and helps us make sense of comparing the results and the methods developments that we still need. Next slide. So this then gets me to how do we leverage the best of both worlds? If our ideal trial is infeasible, I'd argue that then what we could instead do is try to benchmark the results we get from an observational data analysis against a feasible related trial. And so I just want to give one example of this coming off of some of the discussions we had yesterday, which is looking at surrogate outcomes that could be measured earlier in life. That perhaps there are times where we might do a randomized trial with a shorter follow-up period using those surrogate outcomes, but we'd have observational data that had not just those surrogate outcomes measured, but also the clinical outcomes we're interested in the long term as well. And so if we're able to reproduce or replicate the results of the trial with our observational data for the surrogate outcomes, that helps us have a little bit more confidence in the causal inferences we draw from the clinical outcomes too. Now, of course, the best thing that we should do is just triangulate all possible data sources, all possible analytic strategies that are appropriate, and being transparent about how to do that. And so this would argue that we don't just think about this as a one at a time thing, but really doing this with all the available data sources that we have, and also using, again, the quasi-experimental methods we're going to get to in the next talk. Next slide. So to summarize, why do we need observational studies? Well, this ideal large multi-arm trial of midlife interventions is unfortunately not likely to be feasible, at least in terms of the ideal, really ideal setting of it. Even if it was feasible, it's not going to be completed for decades, but it's of substantial clinical and public health interest right now. We need information about it right now. And so thus, rigorously conducted observational studies are really our best bet, especially when complemented with rich scientific debate about the underlying assumptions, and especially when triangulated with other studies, and especially, I think, when benchmarked, if feasible, against some trials as well. Next slide. So then how do we go about conducting these observational studies? Well, I'd say always start with this clear research question: what is the target trial? Conduct our analyses as closely as possible to that. Be vigilant in our attempts to avoid, mitigate, understand, and quantify the biases. And then finally, just be transparent in the presentation and interpretation of the results. And so if you go to the next slide, I'll leave you at that. I want to thank you all again for your attention, and I look forward to our discussion together.
Thank you, wonderful. And I think we can now go on to Emily.
Thank you very much. And thank you to Marianne, the organizer, for the invitation to join this great panel today. Can I have the next slide, please? So here is a brief outline of my presentation. I will start with a motivating example from my own research on the effect of education and changes in schooling on cognition, to try to show you why we might want to use quasi-experiments when we think about building a research agenda in ADRD prevention. I should say that I'm a political scientist and social epidemiologist by training, so a lot of the examples I will give you come from that field of research, but I've tried to venture out to give you examples from other fields that might be relevant to AD and ADRD as well. I will then define what I mean by quasi-experiments and natural experiments, and give examples that might be relevant to our topic today on cognition and cognitive decline, both in terms of asking causal questions about the determinants of inequalities in cognitive function, and also to inform the design of future potential interventions. I will outline some of the strengths or weaknesses of these designs and reflect on possible way forwards to make this type of research design as useful and relevant as possible as we build a research based on preventive research for AD and ADRD. And this will echo very much what Sonia just presented on the target trial framework. Next slide, please. So let me start with an example. So we all know that there are large and persistent associations between education and health in general, and between education and cognition in particular. And this association has been documented in a number of countries using different methods. It's a very consistent finding. The issue, however, is that both education and health, both education and cognition, are in part jointly determined by your early life circumstances, such as your childhood health and parental socioeconomic status, as well as underlying characteristics such as time preferences and cognitive abilities. So disentangling these different factors to assess the effect of education and cognition is incredibly complex. And if you want to try to answer this question about the effect of education on cognitive function, you can take two different approaches, two different research designs, which echo again what Sonia just presented to us. So the first one is a confonder control or backdoor approach, which implies to try to adjust for the potential confounders based on the data that you have. And this approach is very prevalent in epidemiology and public health. The second approach, which is of course the one I'm gonna try to talk about today, is the instrument-based or quasi-experimental approach. It's a very different ways of thinking about it by trying to use a change in education that is induced by the introduction of a new policy, for example, to try to assess the effect of a change in the exposure of interest in education, in this case, on cognition. So really the very basic idea of quasi-experiment is that we don't rely on observables to answer our question, but we try to use an exogenous change in our exposure like a policy. I'm going to try to make it a bit more concrete with a specific example. So next slide, please. So what you have in this slide is an example for a policy that the French government introduced in 1959. It's a compulsory schooling law that forced all children who are born after a very specific date, after the 1st of January 1953, to stay 2 more years in school. So those born just before the cutoff in December 1952 could leave school at 14 if they wanted to, but those born in January 53, February 53, etc., had to stay 2 more years in school. So what the first graph on this slide on your left is showing you is the impact of this reform on school leaving age. So on the x-axis, you have the birth cohort ranging from 1945 to 59, with a dashed line indicating the first cohort that was eligible to the reform and had to stay longer in school. And on the y-axis, you have the average school leaving age. And you have the data separately for men and women. So what that first graph on the left showed you is that there is a jump, a discontinuity in the duration of schooling, starting for those respondents who were born at the cutoff, the 1st of January 1953, the first eligible cohort. They stayed longer in school as a result of the policy. And basically, the question we're asking in this paper is whether there is a matching, a corresponding discontinuity in cognitive score decades after that policy was implemented. And this is what the second graph on the right is showing you. It's the same setup. X-axis, you have the birth score, but now on the y-axis, you have your cognitive score, standardized cognitive score. And what it showed you is that for men, there is indeed a corresponding jump and discontinuity, an increase in the standardized cognitive score beyond what would be expected based on the trend across the birth cohorts, but not for women, only for men. So this is again in substance what quasi-experiments are trying to do, to find an exogenous source of variation to assess whether the change in exposure of interest, so duration of schooling in this case, impacts our outcome, cognitive function here. Next slide, please. So if we try to formalize that definition of a quasi or natural experiment, this one by Marc Pettigrew and colleagues is, I think, very useful. They write that a quasi-experiment usually takes the form of an observational study in which the researcher cannot control or withhold the allocation of an intervention to particular areas or community or individuals, in the example I just presented to you, but where natural or predetermined variation in allocation occurs. So there is a bit of debate as to which approaches exactly qualify as quasi-experiments or natural experiments, but I've listed here 3 designs that leverage those exogenous sources of variation in the exposure. The first one is the instrumental variable approach, with the idea of leveraging a source of variation in the treatment. So for example, in education, that is unrelated to other determinants of the outcome of interest. So an example you could think of is distance to school or college as an instrument for educational attainment that you would estimate in your first stage, and then the impact of educational attainment as predicted by your instrument in the second stage, its impact on health. A second design is the one I just introduced to you with this example from the 1959 French Bertrand reform. It's a regression discontinuity design. The idea is to leverage an arbitrary discontinuity, date of birth in this case, in the probability of being treated depending on age, resources like income, etc. And the third approach is a difference in differences, which takes advantage of data available over time to compare outcome changes among a treated group exposed to an intervention with changes among the control group not exposed or not yet exposed to the intervention. And the US have been an amazing laboratory for researchers who are interested in this type of approach. You could think of the rollout across states or counties of policies like the earned income tax credit or school funding as examples of this approach. Next slide, please. So if we try to locate quasi-experiments among the different type of study designs that we can use, this flowchart, which was published by the Medical Research Council on their guideline for the use of quasi-experiments in public health and epidemiology, is very helpful for both readers and producers of this type of research. So what distinguishes a kind of study is, of course, what is X, so your exposure, whether if it's not an event or an intervention, you have a classical observational study. If X, your exposure occurs naturally and is exogenous, you have a natural experiment, like an earthquake, for example. And if X is an intervention designed to change Y and is exogenous, then you have a strong quasi-experiment. If it's fully randomized, then you have a randomized experiment. Next slide, please. So now that we've tried to define and locate quasi-experiments, I wanted to show you that there are plenty of opportunities to leverage quasi-experimental design to build the evidence base on ADRD prevention. And as Maria already mentioned, I think this type of research design remains really underused in epidemiology and public health, even if it has changed in the past few years as they've become a lot more popular. So to illustrate the potential of these approaches, I took this graph from a recently published and updated paper from Jill Livingston and colleagues, published in the Lancet, where they tried to quantify risk factors for dementia across the life course. And as you'll see, at each stage of the life course that they highlighted, including in early life and midlife, there are plenty of opportunities to implement quasi-experimental design. So let's take the first example in terms of genetic predisposition and carrying the APOE4 allele. There is a lot of interest and very interesting research in gene bioenvironment interactions, but a key limitation of that literature to date had been the definition of the environment and the issue of the potential endogeneity of the environment. New research is bringing in quasi-experiments to address this issue. And there is, for example, really great work by Silvia Barcelos, Leandro Carvalho, and Patrick Turley, showing that eligibility to a schooling reform in the UK, which is very similar to the one I just introduced you to in France, so staying longer at school as a result of a policy change, mitigated the genetic predisposition to obesity. And I think this could be very usefully extended to cognition and cognitive function. Then I've already mentioned early life or early adulthood intervention, but I think there are many opportunities to extend that work to include more pertinent interventions, maybe for ADRD, like policies targeting the quality of schooling rather than just the quantity of schooling. Head Start in the US is a very interesting program that, because its funding is allocated to US counties based on historical poverty rates, and this discontinuity in the allocation of funding has been used to assess the impact of the program on a number of health outcomes, but for example, not on cognition. Of course, the use of quasi-experiment is not limited to the field of social epidemiology. In midlife for exposure such as hypertension, for example, we can think of all the clinical or medical decisions which are based on very specific cutoffs and could really form the base for interesting quasi-experimental study. For example, decisions to initiate hypertensive treatment based on a specific threshold. In terms of health policy, eligibility to public sector insurance in the US is contingent on specific age or income-based cutoff. And all these policy rules or clinical guidelines really make for very interesting instruments to assess the impact of changes in risk factors in midlife. And in later life, exposure to pollution has been added by Livingston and colleagues as an important risk factors. And there, I think, taking advantage of differences in geographical allocation or boundaries can yield very interesting studies. There has been a very influential work in China, for example, looking at policy incentive for different type of household heating on each side of the Huai River. And they showed that provinces north of the river will receive subsidies to use coal at much higher levels of ambient pollution, and as a result, a reduction in life expectancy by about 5 years. So this type of approach could usefully be extended or replicated in other contexts. Finally, on those examples of research that could inspire or directly be expanded to include cognitive outcomes, I wanted to mention that quasi-experimental approaches do not need necessarily a policy or a clinical guideline. They need an exogenous source of variation. And that's especially true for instrumental variables, which are notoriously very difficult to find, but come in all shapes and forms. And researchers are always very inventive when it comes to trying to find instruments. I wanted to mention here very interesting work by Vaina Filian on the impact of depression in later life on cognitive function. We're using spousal death as an instrument for depression to assess the impact of depressive symptoms on cognitive function. So interesting type of works that again could be usefully extended with two potential contributions when we think of quasi-experiment over the life course. The first one is to ask and hopefully answer causal questions about the determinants of cognitive function and inequalities in cognition. And the second is to assist with the identification of effective intervention. Next slide, please. Right, so let me try to outline then the strengths of quasi-experimental approaches, and some of it has already been mentioned by Sonia in her talk. So the added value, of course, of quasi-experiment is to try to generate causal evidence when RCTs are just not possible or desirable for financial or ethical constraints, or because we are interested in evaluating policies that occurred in the past. When well designed and under a number of very important assumptions, they tend to have high internal validity. They try to mimic randomization, and they can be used to try to answer causal questions. A third strength is that they have potentially high internal validity, in the sense that by definition here we're in a real world setting and we're evaluating the effectiveness of interventions rather than just their efficacy, and that potentially, in theory, the findings of quasi-experimental studies could be more generalizable than those of RCTs. And the fourth and really important strength is that they're relatively quick to conduct and low cost with long follow-up, especially compared to RCTs for midlife interventions. And in that sense, they could be a bit more efficient than RCTs when well conducted. Can I have the next slide, please? So, of course, I'm not a panacea, and there are many challenges. The first one being the higher risk of bias and randomized control trials. We do not control the randomization when it comes to quasi-experimental studies, and a sizable body of literature has contrasted findings from RCTs and non-randomized study. A key difficulty is that they are discovered rather than planned. By definition, they occurred in the past, and the intervention that we end up analyzing, like the schooling law I was mentioning at the beginning of the talk, may not be exactly what we wanted to evaluate if we had the opportunity to design our own RCT of an educational intervention. We have to rely on data being available, and as Maria already mentioned in the introduction, they do require very large sample sizes, and it tends to be difficult to have in one place, in one data set, the right data on exposure, large enough sample size to be powered enough, as well as good outcomes. This is changing with more data being available to the research community, but that tends to be quite a challenge. Interventions may not be very well defined. Eligibility and implementation fidelity may not be completely clear. Coming back to that first example about education intervention, this has definitely been an issue, and definitely an area where interdisciplinary collaborations with researchers who know very well from their work in education policy or political science in general, those policy is absolutely key to understand the definition of the policy as well as its rollout over time. So a question when we look at those challenges of quasi-experimental approaches is whether those approaches are given a glow of experimental legitimacy, and that they may not be fully deserving if they are not robustly conducted. And a related question is, what is a good enough quasi-experimental evidence to inform the design of interventions targeting AD and ADRD? Can I have the next slide, please? So this has already been covered by Sonia, but the target trial framework has been adapted, adjusted by De Vogt and colleagues in a paper published a few weeks ago for quasi-experiment. And I think it's really a very important development and way forward, because it provides a systematic basis to assess the plausibility of the different assumptions and claims that we have to make sure that our approach is robust. It really gives us a structured method for assessing all the different design elements that Sonia already detailed. So this is, I think, a very important development to increase our confidence and the assessment and the reporting of quasi-experiments. Can I have the next slide, please? Right, so to conclude, well-conducted quasi-experimental approaches can generate robust causal evidence from observational data to inform the prevention research agenda. I really believe that fully embracing interdisciplinarity is absolutely key to achieve this goal. These methods have been developed by, among other, social scientists, and it's a very fast evolving field. We do not conduct difference in differences study today the way it was conducted even a year and a half or 2 years ago. So we really need to keep up with those methodological developments across different fields, and training is needed to equip public health researchers with the necessary tool. Wanted to mention that there is a lot of effort ongoing in that field from colleagues like at UCSF, like Eli Mathey, or at Penn, at Inder Vekaramani, who are really trying to translate across discipline the different terms, notions, and methods to ensure that we're talking about the same thing. As Sonia already mentioned, transparency and replicability can further strengthen trust in those methods. Target trial framework is one possible way forward, and I fully agree that pre-registration, falsification, and trial regulation should become the norm in the field. Next slide, please. And this is just to say thank you for inviting me in this panel, and I look forward to the discussion.
Thank you so much, Amelia. That was really wonderful and gave us so many ideas. I think it might be time for a break before we go to the next talks. Yes, so we will return in. All right, great. See everybody at 3:27. Thank you. And so now I want to just transition to Dr. Julie Zissimopoulos. And Julie, thanks for joining us. Take it away.
Thank you, Maria. So thank you to Drs. Maria Glymour and Jonathan King, and of course, my excellent co-panelists who set the stage so well for my presentation. I acknowledge support by the National Institute on Aging through their grants listed on the slide. Next, please. So I will be presenting on two main topics, the use of healthcare claims data to generate real-world evidence on opportunities to reduce the risk of dementia for drug treatments for common chronic conditions, and then talking about employing dynamic microsimulation methodology to quantify the effects of improvements in population health on future population prevalence of dementia. Next slide. So we may be able to reduce dementia risk and importantly, disparities, racial and ethnic disparities in it with drug therapies currently being used to treat high prevalence conditions such as hypertension, hyperlipidemia, diabetes, many that we've already seen discussed in the panels. So use of drugs like antihypertensives and statins to treat their associated health conditions is already high and has been rising over time. And because conditions like hypertension are associated with increased dementia risk, the effect of the drug treatments, antihypertensives, may be acting on dementia through hypertension control. But drugs may also have pleiotropic effects, that is, mechanisms that act directly on dementia pathology. So one approach to reducing dementia risk may be through repurposing these drugs, but this is not what I'll speak about today. Instead, I want to talk about opportunities for dementia risk reduction by changing the drug treatments in the population with that particular condition. So for example, adjusting the drug class that they're using or achieving better adherence, or reducing the use of drugs that are associated with increased risk of dementia, as was mentioned in the prior panel. Next, please. So the value to utilizing real-world evidence in the study of prevention was made explicit in the 21st Century Cures Act that pointed to the use of data not derived from clinical trials to support the approval of new indications for approved drugs. But this will require a multidisciplinary research approach with experts in basic and clinical science, data and social science to generate hypotheses about drugs and importantly, their mechanisms of action, to understand data quality, develop rigorous study design and methods, and also forming appropriate expectations about what we can learn and what we cannot learn. Next slide, please. So our research approach for using real-world evidence began by convening multidisciplinary experts in neuroscience, geriatrics, pharmacoepidemiology, and in my field, economics, in a formal group judgment process on drugs for chronic conditions and their likelihood of impacting dementia risk. We completed a scoping review that identified 400 human studies on the association between dementia in 29 different drug classes across 11 therapeutic areas. It's a very active research, but the rigor varies across studies significantly. This study also illuminated gaps in the study of particular drug classes and large gaps in the study of racial and ethnic heterogeneity. So we prioritized the list of drugs for study. We weighted drugs for highly prevalent conditions where treatments may exhibit racial and ethnic disparities and where there was a strong hypothesis around the mechanism of action on dementia, not just through the drug the condition is treating. So we collaborated with different clinical basic science experts, depending on the drug class we were studying, to help us generate hypotheses and inform our data analysis using healthcare claims data. Next slide, please. So there are many strengths to using claims data for this research area. Importantly, allowing large sample sizes that allow you to look at specific drug classes. This is very important because many drugs to treat the same condition have different mechanisms of action and so may differentially affect dementia risk. And as been noted many times, it allows for the study of heterogeneity effects for males and females and across racial and ethnic populations. But large amounts of data can lead to data mining. However, if we work across disciplines that can support hypothesis generation and testing as opposed to data mining. There are, of course, challenges, threats to validity that have been discussed in this panel, and I've listed some of the primary ones. And I will discuss our approach to these potential biases by the way of two studies. Next slide, please. So many studies and across the 2 days have talked about antihypertensives and dementia risk. And Sprint Mind and other studies found that blood pressure management reduced dementia risk. but there may also be indirect effects of some antihypertensive drugs on dementia via the renin-angiotensin system. So our colleagues, Patrick Keogh and Whitney Wharton, both who are neuroscientists, have been studying this relationship between RAS and Alzheimer's disease. And theirs and other studies have suggested that RAS-acting antihypertensive, so those are the ACE inhibitors and ARBs, may modulate protective mechanisms against Alzheimer's disease. And ARBs may be more protective than ACEs because ACEs' role in amyloid B degradation. There's also hypothesized that there would be differences for Blacks who have higher endogenous sodium and lower renin compared to whites, and for women compared to men due to the effects of estrogen on the RAS system, but unknown implications for Alzheimer's disease. So despite this RAS-AD link by our colleagues in this study and others, there's been limited population-based investigation in samples with representation of women and racial and ethnic minorities. So we don't have a lot of evidence on the cross-class differences for specific subpopulations to inform generalizability and population health more generally. So we tested the hypothesis that the renin-angiotensin system acting antihypertensive, so the ACEs and ARBs, confer more protection against Alzheimer's disease than other antihypertensives, specifically diuretics, calcium channel blockers, and beta blockers, and ARBs more so than ACE inhibitors for the reasons I discussed earlier. And we analyzed the differences for Blacks compared to whites and women compared to men, again, for the hypothesized differences explained earlier. Next slide. So I'm going to turn to our method. So our study sample was a 20% sample of persons over age 65 enrolled in traditional Medicare who were users of antihypertensives, and that was over 1 million. So we used longitudinal data and multivariate logistic regression to quantify the effect of incident AD diagnosis of RAS acting, so the ACE and ARBs, relative to non-RAS acting antihypertensives. And we quantified these in subsamples. And now I just want to talk a little bit about how we attempted to address several sources of biases. So we tried to address misclassification bias on our outcome by requiring at least 2 diagnoses of Alzheimer's disease over time. So taking care of rule out diagnoses. And on drug use variable by defining antihypertensive users of the 5 different drug classes based on days supply, so days filled over 2 consecutive years. And importantly, in sensitivity analysis, we varied those days. Note that because we're using a sample of all users and we're comparing across drug classes, our underlying assumption is that any misclassification bias is the same across the drug classes. So that is no differential bias on relative risk across drugs. We addressed reverse causation by requiring no prior Alzheimer's, dementia, or MCI diagnosis and defining antihypertensive use prior to incident Alzheimer's disease. We tried to address confounding by controlling for demographics, healthcare use, diagnose comorbid conditions, those that are the primary risk factors, and use of other drugs, such as statins. And then we merged data from the ACS with the beneficiary zip code, and we use that to proxy for socioeconomic status. So our key identification assumption here is that sorting into one of these antihypertensive classes after adjusting for these confounders is uncorrelated with dementia risk, so no unobserved. And then we address selective attrition by restricting our samples to beneficiaries who survived, continuously enrolled in fee-for-service Medicare through the end of the study period, and then using robustness analysis, including those who do die along the way, to see if our results our estimates are robust. Next slide. So we found strong evidence that was consistent with our hypotheses that ARBs reduce risk of Alzheimer's disease relative to non-RAS acting antihypertensives, but there was no risk reduction associated with ACE relative to the non-RAS antihypertensives. The sex differences were consistent with the hypothesis of the estrogen interaction with the RAS system, but we did not find strong evidence for differential effects among Blacks and Hispanics, although we didn't have hypotheses around Hispanics, a much less studied group. But again, as you can see, our estimates are somewhat imprecise. So for the last several minutes, I want to change course from talking about reducing individual risk and talk about how we might use a different type of methodology, dynamic microsimulation methods, to think about and project the impact improvements in population health on the future of dementia prevalence. Next slide. So the answer is complicated because there is a dynamic interplay of health conditions and other risk factors, such as age associated with dementia. So very simply, by improving population health, for example, reducing population prevalence of diabetes or hypertension or cardiovascular disease, we likely increase longevity and through that dementia risk. Next slide, please. So our approach to trying to understand, and you can please just move through the animations. We employ the Future Elderly Model for dementia, which is a dynamic microsimulation model that has been developed for almost 2 decades with funding from the National Institutes on Aging. And it utilizes nationally representative and longitudinal data from the Health and Retirement Study. So the big picture is we estimate the demographic health and socioeconomic factors associated with dementia onset over time. And that dementia onset in our models impact mortality risk in models of mortality. At the same time, we're estimating models of disease and health conditions onset, that is diabetes, hypertension, and these diseases affect dementia onset and also mortality. Then where dynamic microsimulation comes in is we can project life expectancy and dementia prevalence under different scenarios about population health, improved health through lower risk of diabetes or hypertension, and we contrast that with a hypothetical new dementia treatment. And we do this for 2 different cohorts. One is a nationally representative cohort of individuals 51 and older, and then also for the US population, where we utilize the health trends of younger birth cohorts from the NHIS. So a key assumption is that the measured associations in these models are valid into the future. And importantly, in the results that I will show you, we're not modeling the pleiotropic effects on dementia risk of the drug treatments for health conditions. Okay, next slide, please. So what this graph shows is life expectancy in years at age 65 under the various scenarios. The first being the status quo, so there's no change in population health. And then 3 scenarios of health improvements: reducing incident hypertension by 50%, or achieving no hypertension at age 50 and no incident thereafter, reducing incident diabetes at 50%, and then this hypothetical innovation that's able to delay dementia by 2 years. So what we see is the results of all scenarios compared to the status quo is more years of life, about 1 additional year of life in the no hypertension scenario. Next slide. When we look at this from the trade-off between life expectancy and lower risk of the health condition on the change in the number of 85 and 86-year-olds with dementia from a cohort simulation, we see the only scenario that results in fewer numbers of 85 and 86-year-olds with dementia is something that's acting directly on dementia. So the life expectancy is outweighing the health. Next slide, please. And when we look at this from the population projection, the population perspective, that is projecting the number of Americans with dementia 20 years into the future, we see that the public health improvements do not lead to lower population level numbers. Only a innovation or some sort of intervention that acts on dementia results in lower numbers in 2040. Next slide. So I want to talk a little bit about the ADFEM more generally, and please move through the animations. So the ADFEM, this kind of modeling, can be used to gather and interpret information from clinical trials and other interventions. So for example, if you have a clinical trial where the intermediate endpoint is cognition, modeling can help us interpret how those changes in cognition are going to be associated with changes in functional health, institutionalization, how that might impact the health of the care partner, and allow us to quantify the cost and value of treatment for individuals, their care partners, and then ultimately for the population, society level. Next slide, please. So please feel free to email me if there are any questions that are not addressed in the Q&A. And finally, in the last slide, I just want to acknowledge my co-author on these and other drug studies. So thank you very much.
Thank you, Julie. That was terrific. Really interesting work, and a big arc of work that's quite challenging. I think we have a few minutes for discussion before our break. So let's see. I wanted to start Thank you, Jessica, for trying to coach me here. I wanted to start with Dr. Atkins-Jackson had raised a question, which I want to put out there, and then maybe we can return to it in the longer discussion because I think it's challenging, which was really about whether people are familiar with policy-related prevention interventions that really target structural racism and bias, and whether those have been at least shown promise to decrease the long-term risk of dementia. And I will open that up to any of our speakers if people have thoughts on that.
Panelists are encouraged to turn their cameras on.
Thank you. Perfect. That's much
Just
better.
quick line.
Yeah. Emily, do you think of the educational interventions as potentially a manifestation, sort of educational inequalities as a potential manifestation of structural racism that's relevant for that?
Yeah, that's exactly what I was thinking. With the limitations that I mean, the quasi-experiment looking at education policies have not really looked at specific subgroups as far as I know, and that might be an important limitation to keep in mind when we're thinking of the use of quasi-experiments for dementia prevention, like with all the power issues that we have been looking at, we've been discussing. I think it's definitely a blind spot in a lot of the work that we have been doing, that there is no systematic investigation of subgroups, even if those policies are definitely very relevant. All the economic policies, economic opportunity policies, I think, are definitely very relevant when it comes to thinking about structural racism, but specific subgroups, as far as I know, they are not very often investigated, unfortunately. But I wanted to point towards the work of that is done at Opportunity for Health Lab at UPenn, where they have they do a lot of quasi-experimental work on structural racism and health disparities. So it's not it's policy related in the sense that they look at policy, not policy that prevent racism or reduce racism, unfortunately, but the other way around. But it might give the person asking the question interesting ideas and references. So I will add the link to the chat. It's really great work that they do there.
Oh, thank you. Terrific. And I will say I agree with your assessment that there have been real data challenges in actually understanding adequately differences in effects across race, but I do see some of the work emerging. So I think Justina Avila, whose work I mentioned a little bit earlier, Marilyn Thomas in my group is looking at things like HBCUs and as a resource. I think that's starting to happen, but I also think it's really worth pushing as a priority, is to have data structures that can support that. I don't know if other people, Rachel, did you want to add, or anybody wants to add to that perspective? And then we have a bunch of other questions as well. So.
I can point out briefly that at NIH recently, when we were reviewing what work we had been supporting in this area, it was remarkably difficult sometimes to actually sort of find it called by how we're trying to understand it now. So there has been a lot of work. Well, it amounts to policy differences, but we're actually, frankly, phrased in terms of race or structural racism, and so it's been interesting. But that's an ongoing effort at NIH that that hopefully you'll be hearing more about soon. That's what I can say.
I think our next question is for Sonia. Would these ideas of emulating a target trial be included in future epidemiologic research education? It seems like many people, including me, and I don't know who this question was from, but have been trapped in specific, but I think it could be many people in EPI, so you're in good company, have been trapped in specific observational study designs, cohorts, case control studies since the beginning of our education and forget why we do observational studies in the first place. So agree with that. Endorse. Sonia, you want to respond?
Yeah, I think I'm basically going to endorse it too. So first, I should just say that there was a paper by Jeremy Lebrecq and I that was cited at the bottom of a lot of my slides that is actually titled Teaching Target Trials. And so a lot of it is really just the themes of what we gain from framing our education around that. And I've done a lot of work in the institutions I'm involved in. I actually also just want to say, like, for me, this really goes to fundamentals that can go well before you get to the point of being an epidemiologist or whatever kind of health scientist you want to be. And so just to kind of illustrate this, I actually gave kind of a career talk lecture at my high school earlier this year, where I was kind of helping them understand what it means to be an epidemiologist, and especially during a pandemic, like thinking through that. And I used target trials as a way to kind of bridge how to make sense of all the noise of the literature they're kind of getting hit with from the media, of like trying to see what are the studies that, you know, are finding effects or finding ways to prevent or treat COVID, and then trying to think through like the ones that are noisier as being the ones that are harder to map onto a clear target trial. And so I think that there's a way to kind of reevaluate just how we think about health science in general with this, and not just like graduate school epidemiology. But I'd love to hear what other panelists think about this too.
I just have one quick comment, which is I think this was kind of a theme throughout, and Maria started with it, is the importance of interdisciplinary, because we do bring different methods, all the different disciplines and approaches. And I myself have been very grown a lot from working with people across the disciplines as an economist, working with epidemiologists, and then obviously basic and clinical scientists. So I think that's definitely a way forward.
I'm glad to hear that, Julie. I was actually, because I feel like there's such a schism in terms of econ approaches to to instrumental variables and quasi-experimental approaches versus the epi, and it's kind of remarkable to stand at the boundary, because the epidemiologists think the IVs are crazy and the economists think the non-IVs are crazy. And if you see those coming together and more conversation across the aisle, as it were.
Yeah, just to add to what you are saying, Maria, I feel like there is a lot of very interesting work that is coming at exactly that intersection that you are describing. And both as someone who is trying to do some of that work, but also a reader of that work, I think it's work that is really very intellectually stimulating and very interesting at the boundaries of all those disciplines. And so if people are thinking about potentially going in that direction, it's very demanding. It's a steep learning curve, definitely, no matter which discipline you come from. But the rewards are really, I think, worth the effort, both in terms of what you're able to do, but also the intellectual challenge and stimulation that you get from working at the crossroads of different disciplines. It's not always easy, definitely, but I think it's definitely worth trying. Yeah.
Thank you. That's terrific. Before we go on to the next question.
On that.
Go ahead.
Sorry, I couldn't find my raise hand.
Oh, that's okay. Jump in, Lauren.
But I think one other related point to that is sort of the challenge in communicating to different audiences, and particularly like a lot of this work, we want to get to clinical journals where it reaches a large audience, and having reviewers who understand and value some of the methods can be very variable, and also it's definitely not something that we're taught in grad school, or kind of how to communicate that way. So that's something that could also be of value in like interdisciplinary training programs and postdocs and conference sessions that sort of deal with that.
I think that some of that is really a reconceptualization of what science looks like. I mean, I think that I had a vision when I started of like, I would write a paper and it would answer a question. And really now I think of, I will write a paper and it will be a tiny little slice of a large arc of argument about a question. and understanding that any given study is going to really has to be conceptualized within the context of its strengths and weaknesses. And the thing that I love about IVs is the assumptions are just different. Like I don't think they're particularly stronger, but they're different than the conventional methods. And so to me, that makes them much more valuable in the context where there've been many, many observational studies. I want to make one link back with Sonia's, with the emulated trial design. And one of the things that I really like about it, linking back with what Richard Gershon said when we were talking yesterday about the intervention, really we need to think about changes in exposure. And we haven't been doing a very good job of focusing on changes in exposure, because that's what the intervention could be, is a change in exposure, not a level. And I think the emulated trial design really pushes us to do that in a way that you almost don't need to think about it with an IV or quasi-experimental approach, but with an observational approach, you really do. And so I really appreciated that yesterday when it was raised. And I think it supports this kind of new framework for the design. Okay, we have a question for Sonia from Linda Collins. Linda, did you want to ask your question, or shall I can read it? A question.
I'd be happy.
Yeah, go ahead. Yeah,
okay.
Better to have more voices.
Yeah, I mean, I didn't write it very well, so it might be better if I just ask it. So I was thinking, Sonia. So I don't. You may or may not have seen the previous panel, but I talked about conducting optimization trials as a way of kind of looking inside the black box of interventions, and those kinds of trials. And those kinds of trials you can, well, for example, they're often factorial experiments or something in the family of factorial experiments that enables you to assess the contribution of individual intervention components. A question I get a lot from people is whether it's possible to reanalyze existing data from observational studies rather than go to all the trouble and expense of an optimization trial. And so far I've been saying no. But after I saw your talk, it made me wonder if maybe there might be some circumstances in which you could do that. So I just wondered if you could comment on that.
Oh, sure, thanks. So I have to say, I'm glad that I saw you post this question. So it was something I was kind of mulling over for the last 20 minutes or so, which gave me a little bit more of a leeway to think about it. So I think my short answer is really just the classic, it depends. I would say I would want to see a lot more work first to understand how the biases might propagate in your decision making downstream from this. So like if you were using observational data to estimate a component that then helps inform the next phase in your optimization problems, and you estimate that poorly, then what does that do downstream to all the other decisions you're going to make, and maybe an eventual trial you're going to run that isn't going to be as successful as you think it would be otherwise. And so I guess this gets back to just kind of owning and being transparent about the biases that come up with any observational data analysis. And this would come also to any of the quasi-experimental analyses too, trying to inform that same sort of input. Is I would just want to really think through plausible violations of the assumptions for those inputs. But then what would be new to me to think about is how those propagate to the next decisions you're going to make too. And I would imagine that'd be a lot of methods work and maybe a big NIA or other grant somewhere down the line to think about.
Yeah, I think you're right. And I love the way you put this answer in a decision-making framework, because I feel like that's the framework to use here. I thought that was really great. Well, thank you. It's an interesting question. So to me, I feel like there's not enough observational studies where the effects, where there's been any kind of accidental individual manipulation of components. So that's to me that's the big issue. I think in theory it could be done, but in practice, I just don't think the right data are available. But it would be great if it could be done, because it would move things forward faster. Mm-hmm. Thank you.
Sure, thanks.
I want to we'll return to that maybe in the general discussion, and enlist Jason Doctor to talk about healthcare settings in particular. And Rachel, I'm just giving you a heads up so you can think about what you're going to say about this question of whether we can really use, because places like Kaiser seem like really perfect little in situ experimental settings. Even if they didn't intentionally do the experiments, they have policy changes that create little components. But there's another question here in the chat, which I want to get to before our break. Much of our work from Karen Schleip, I'm sorry, I mispronounced her name, I'm sure. Much of our work focuses on all-cause dementia, which makes sense in many ways due to the high prevalence of mixed pathology. But do you think that, and this is for all the panelists, believe that evaluation by dementia subtypes for all the various methods presented is necessary before we can really get to true modeling? And this, I mean, this is like such a tension in the field, is all-cause, specific subtypes, do we need biomarkers? Can we make progress with all cause? Julie, I feel like you probably struggled with this quite a bit.
Definitely. I was going to give one example, and I'll start with the Sonia clause. It depends, but in our work in progress right now on GLPRAs, that is a very hot topic for us because the hypothesized mechanisms, and I'm not going to discuss them because that's not the economist part of that. That is my colleague Hussein's part of it. But the hypothesized mechanisms of that drug, which is in clinical trials for repurposing, is not for all types of dementia, is for specific types. And so I would say, generally it is very important in some cases, probably more important than in other cases. I'll stop there because I'm sure everyone has other things to say about it.
I can say that people have been trying to propose these kinds of things for a long time, but when you get into study sections, it's basically one of these disbelief exercises among the neurologists, whether or not you really are subtyping these things correctly or whether anyone can subtype these things correctly. And it gets very complicated. I mean, basically, if we look at data from Ross Map, where you show that like everything is sort of multi-causal, it's sort of disappointing there. But on the other hand, I have to say, down deep in my heart, I sort of think that, gosh, what you got out of Sprint Mind and the superior results there almost certainly had to have been at least slanted towards, the reduction of dementias that would have all been vascular. I can't prove that. It would be surprising to me if it turned out that that was completely wrong. I mean, I wouldn't know how that would work, or if we knew anything about how vascular dementia would work at that point. But it's been so hard, and people have tried to use our largest data sets, our best data sets, to try to do these differential diagnoses. And when we have the postmortem data, it just doesn't look as good as you'd think. I don't know what to say.
Go ahead, Rachel.
Well, no, it's John sort of said what I was thinking, but even when you do these different subtypes, and we do that in our cohort studies, it's not a perfect correlation with what you do see in postmortem pathology. And so what you see in postmortem pathology is sort of, as this comment says, very, strongly showing that there's mixed things going on. And so then that begets the question of what exactly is happening in the brain. And so if you wanted to make a targeted approach, it's hard to base it on the clinical phenotype. I mean, you can, base it on the clinical phenotype, but if the clinical phenotype isn't lining up with sort of the cerebropathological phenotype of what you see, then, where do you go from here? And so I just, I think, I can't see how, these putative risk factors that we do know about, I just think that they have different mechanisms in how they may help or hurt the brain. But I don't think we're at the point in science where we can say that they only impact some of the things that happen in the brain because of that weak correlation between what we do see, and again, it's who does decide to donate their brain, and you can get into that whole discussion. But because that correlation is weak between what you see clinically and what you see in the brain, I don't think we're ready to say that there's just one thing going on.
I feel like this is actually probably one of the most important problems, is this issue of data sources. And there's this direct tension, as I think Melinda mentioned, between what we measure and who's in our study and how big our study is. And in my hands, the biggest challenge with quasi experiments is the statistical power and precision. I thought it was all the exclusion restriction, but I will tell you it's confidence intervals. So to really support those, we need very large samples. And to have really large samples, it means that we're giving something up in terms of the quality of the phenotyping, of the outcome phenotyping. I mean, one way forward might be better designs for very targeted measurement. Like I thought that Adams was transformational for HRS because they had really good measurement on the subsample. And if we could think about how to do that in a better way in some of the large administrative data sets, maybe that's a way forward to try to get at this, to try to give us more information about the specific phenotype or the specific mechanisms and biology underlying changes. Although I would love to see, first of all, anything that we really had convincing evidence worked. So for all cause. Emily, go ahead.
Yeah, I was just thinking that there is a strong push in Europe, at least in the UK and Denmark, to try to augment or create or augment the administrative data set that they have. And in Denmark, they have an amazing registry data that we've been using for quasi-experimental research. And it's really quite wonderful because then you have really high power. And I think they're really keen on validating a number of cognitive and dementia diagnosis measure, but also incorporates some biomarker data through GP test results. And the UK is taking the same approach. The National Office for Statistics is merging a number of data sets to create a Danish type registry data, including with tests from GPs. So it's not my area of expertise for that, but I think a lot of that data, or at least some of that data, might become available for very large sample sizes and unselected populations as well, which is really interesting compared to the UK Biobank or the French equivalent in Constance. There is no healthy volunteer bias in things like the Danish registry, for example. So I think it's very, very promising, the merging of all those data sets, and very exciting for the type of work we're talking about.
Terrific. Are we going to take a break, or are we going to just transition into the big discussion?
I think we should take that short break because I think some people were depending on it. We can let them know that they should be back in 5 minutes so that we can have as many people back on screen and in the loop as possible.
Okay.
So I guess that's 4:35 then. Let's call it that. Or 4:35. We'll be back onto the Zoom here. Okay.
I want to thank all the panel 4 panelists.
Yes, it was beautiful. Yeah. So heading into this final discussion, it is unfortunately the case, and I knew this was going to happen because this always happens when you have a multi-day meeting, when some people don't have to show their smiling faces around the tables. There aren't as many people from day one left as I would have liked, but there are some. And so I think that there are some questions that we can try to do that would bridge across the topics treated on both of the days. I think actually at some level, we're coming up in similar places from both days, which is, spoiler alert, we need more data, a lot more data, perhaps larger sample sizes, and and some of the things that we're missing in current studies, either observational or trials, are things we should be able to fix in some cases. I guess is the real issue. So Beth, I see you're here, or at least you are here in theory. I still come back to the idea that you mentioned in slides yesterday about what if we started, some kind of a cohort that had enough age coverage for long enough, measuring enough things to at least sort of get, some kind of a normative idea about where we really were with respect to some of the things we could measure and what their outcomes would be. I know you were what you would just sort of thought that we need something, and I know you sort of threw it up as an idea, but realistically, what would we want to see in that? What do you think?
Yeah, I mean, I think this just got brought up right before the break. This need for kind of more comprehensive data in these data sets. I mean, I think one thing that's really stood out to me during the 2 days is that the amount of expertise needed to solve this problem, it really is spread out, and there's no subset of folks that have spoken that could do this project. I mean, it really, the people that have the best ideas for what target to reach are not the people that are developing the high frequency collection tools or developing the plasma markers. So it seems like there needs to be some sort of consortium like on this concept of, how would we leverage these different infrastructures to enable like an actual reasonable approach to target something in midlife. I think the plasma and the actual data collection for these opportunistic kind of cognitive assessments and day-to-day measurements, it seems like that is available, just not integrated in some sort of kind of central way. But it's still, I mean, we haven't really talked at all about what the actual target would be for an intervention. So I don't know, to me, it seems like everybody would have to come together to like build this central resource, and then I don't know, some sort of competitive mechanism to decide what actually would be targeted or intervened on.
No, that's a fair point. I mean, what I always try to remind people of, in terms of from a cost perspective, because even with all the additional money that NIH received, costs still don't turn out to be pretty relevant. So everyone loves HRS, but HRS was basically $1,000 per person per year, right? And that's with no imaging and with relatively limited biomarkers,
Mm-hmm.
Now, some of the biomarker prices are coming down. So if we really thought that in many cases we could deal with fluid biomarkers rather than having, say, amyloid PET on everybody, I've now notched down my costs by 10 or 50 times. If the more rapid high frequency cognitive testing, cuts us down by another factor of 10 or something like that, that'd be impressive too. If I drag someone into a neuropsych lab, know that's pretty much on the order of $1,000 too. So if we're getting down to $100 or $10, you can start to sort of see how you could get some amount of size and scope. And certainly a lot of the things that we're talking about in today's presentations required those kinds of sizes, but frankly, the trials are going to too, particularly in middle age. So unfortunately, I don't think Marty Slinsky is able to be here today, but he's right. The sort of the normal rate of cognitive decline, age rate of cognitive decline is like 0.03 standard deviations per year, which he actually thinks, and I think he may be right, you can possibly measure with an intensive thing. But the difference between that trajectory and one that may be a bit steeper and maybe abnormal, maybe that's what 0.05 or 0.06 standard deviations per year is going to take a while. It's going to take a lot. And so that's where I sort of see, a big, I don't know how we're going to get anywhere without doing it, but it's not easy to see how to put it together to do it. So anyone has any questions here or at home on the chat, let us know what you think, because it's really, that seems to be the crux of it.
Rachel, did you have a thought?
Oh, it was just sort of a general comment that, I think it's great what we just talked about. And I think this idea is fantastic. But I also think we need to also keep thinking about the science behind who does go into studies. Even those who sign up for an observational study, which isn't as involved as a trial, they're still different from other folks, and folks in a healthcare system are different, and definitely folks who end up in a trial. And there is a whole scientific field about recruitment, engagement, building trust, and stakeholder opportunities on both ends. And I think we've come a long way, but I think we have a lot more to do with that as well. So it's just kind of a general comment about just keeping that in mind as well, that when we do come up with what we think might be the magic recipe, how do we offer it and cultivate trust and build a bank of evidence in people that do truly represent the population, and people that might be at higher risk. So it's just kind of a general comment. I don't think there's one answer to this, but I just wanted to throw that out there.
Thank you. One thing I liked about Beth's proposal yesterday was the idea that we have this observational study and then embedded in it are trial components. And I think that kind of fits with the MOST framework. It's my understanding of the MOST framework as potentially trying to understand mechanistically what's working and respond to evidence about what's not working to improve. So it seems to me like we need to start at both sides. Like Ryan just put in the chat this question of, do we need more data or better methods to leverage the data we have? The answer has got to be both. Yeah. Like when Melinda and I have worked on this grant to try to line up RCT evidence and observational evidence, and it's actually really surprising how hard it is and how big the disconnect is. And she showed some of that. Like I find that figure that she has where it shows the percentage of people who could participate is like 2%. It's sort of astonishing. So I think we need to do a better job with the data that we have in order that data could really give direct evidence to what should be done, and then also create structures so we can try stuff and find evidence.
So Linda seems to have her hand raised. Yep.
Yeah, okay. I'd like to follow up on what Maria just said. It seems to me there's two different ways to approach this, and they're not mutually exclusive. To some extent, they'd have to take place simultaneously. But one is you can keep collecting evidence, and then when you feel like you have enough evidence, make a decision. The other is you can decide you need to make a decision, and then make the decision on the available evidence. And one of those, this actually comes up a lot in intervention optimization for reasons I won't go into, but one of them is what I call conclusion priority mode. And that's the way we've all, had the traditional hypothesis testing way we've all been trained to operate in the kind of results that go into academic journals typically. And the other I call decision priority mode. And that's where, like, for example, you have to make up an intervention out of components, and you've conducted an optimization trial, and you don't have the option of saying, well, we don't know. You have to decide, are these components, is each component going in or not? It's in or out, and you have to make a decision. And I feel like, in some ways for this problem, the field is, and maybe NIH would have to do this. It's going to have to say, we need to decide whether or not to do X by this certain date. And then you take a more Bayesian approach, which is, let's look at the data we have and make a decision based on the data that we have. I'm not saying don't do traditional inference, but I think every once in a while you have to stop and say, the information we have is imperfect, but if we wait until it's perfect, we're never going to move ahead.
I have somewhat mixed feelings about this, because in my brain is both like aducanumab and also, should people be managing hypertension better? And so maybe like my response to that kind of depends on what kind of interventions we're talking about, and whether we're talking about interventions where there's a plausible harm. And like, part of what's interesting about Julie's interventions that she was talking about is we're already doing those things. They're actually in the field already. And so at some level, we've decided we can deal with the harms. And so then we are making, like, by default, we're making a decision, even if we're not admitting that we're making a decision.
Well, that's interesting. Sorry, go on.
We also have to recognize the cost and benefit of the science changing, right? We've all just been through COVID, and there was a lot of scientific communication that came out, and there was a lot of things that were reversed or changed, and some of them, yes, reflect the best possible science we have now, but we have to be careful that as we communicate this broadly, beyond the scientific community, we're doing it in a way that we don't embed distrust in what we tell people.
Absolutely.
So along the lines of drugs that we're already using, there is in fact a large, just started NIH trial, the preventable trial, which will be interesting if it actually works. It is in fact, a statins, another version of a statins trial, looking at the same kind of, or trying to tickle the same, does this really, fit with at least some of the epi that it could help. But all I can say is that trials of that scale, it has to be very large, and of its length and whatever are quite expensive. It would be really great if one could do more just to have these embedded in healthcare systems generally, because even though this is considered a relatively pragmatic trial, it's not it's not low cost at all, and that's where it is. And the thing is that I think a lot of the uncertainty issues, and I see that Eliezer and Liz are both, our division directors are both still here. One of the concerns, of course, at NIA in terms of sort of deciding stuff is precisely that, you know, when we're talking about the prevention of dementia, you know, you sort of don't want to get caught saying something that turns out to be wrong. People have no problems with NIA messaging, you know, physical activity or cognitive engagement or social, you know, social cohesion and attachment, because we think these are all great things. We can't see a possible, you know, downside. But, you know, when you try to, you know, do as the Lancet sometimes suggests, it's like, oh yeah, no, this is going to be protective. That's where, you know, there's sort of institutional line that we don't like to cross. And even if you give us a deadline, I don't even know if it's in our DNA to do it. I just don't know.
I mean, the U.S. Preventive Services Task Force does this all the time, right? Like they have.
Yes, and they always say we have inconclusive evidence. I statements are the norm, right? You have to remember that even screening for, you know, cognitive decline or dementia is in fact an I statement still. They do not believe they have the evidence in hand to recommend it as, you know, an A or B kind of a practice. Now, part of that is, you know, because arguably some of the studies that have attempted to show that it does benefit, you know, or we're lower quality, we need better studies. And so we can do that. We can help there. But a lot of it is the fact that, you know, although a lot of people in the field assume that the risk of understanding that you may have Alzheimer's disease, you know, that should be helpful. It should, you know, at least enable you to seek better treatment or whatever. You know, there are risks too. You sort of say, well, would that increase suicidality? And do you have evidence that it doesn't? And all of this kind of stuff. And so even in our framework for making decisions of that kind, with the USPSTF, when you actually look at what they're looking at, which by the way, is primarily large randomized trials, yeah, they fall off of that do not read cliff pretty quickly. That's where we're at. And it is hard. It's hard. But that actually is interesting too, because it actually at some level makes it harder for us to do things in larger healthcare systems, because if everyone were screened, we'd have more people we could potentially enroll in some of these trials than we do now, when we know we're missing, you know, a large number, probably the majority of cases still in most cases.
I still feel like we could do a lot better with the data that have been accumulated. Yeah. And thinking about Rachel's work, and Jason, I thought your talk was like totally inspiring and cool. And like, if we look backwards at stuff that has been done in these settings, whether intentionally or not, it seems like we should be able to leverage those changes better. I mean, Kaiser must have had 1 million changes to how they manage hypertension. And yeah, go ahead.
Yeah, I agree. I think HMOs offer an opportunity for sort of longitudinal study of patients. It's not perfect, but it's pretty close. You know, especially people who, again, you know, there's selection bias issues. Some people stay in those systems, other people leave, but to the extent we can leverage that, I think it's useful.
I think it's particularly useful for things, you know, for exposures that are too dangerous to have in a clinical trial setting. You know, like really severe low blood sugar episodes where you end up in the hospital, or, you know, and then looking long-term, like, what does that do to your risk of dementia? That's not something you can do in a trial setting. And it's not even something you could do in like a cohort study where you enroll people, because it's such a rare exposure. I mean, you need 20, 30, 40,000 people. So there's certain questions that, you know, and I thought your talk, Jason, really well encapsulated that. There's certain questions where we do need to leverage the HMO data, and we do need to think about it as an opportunistic or naturalistic observational kind of experimental setting.
There are even opportunities for randomization there if you have an event that is harmful to patients, and you can try to address that through changing physician behavior more rapidly, continuity of care, et cetera. Then you can study the long-term effects on patients.
I mean, we really need markers that show us more quickly what's working though. Like it's a big challenge. And I think that's part of the challenge with the most framework for dementia is it assumes that you can learn quickly what was working and act on that evidence, right?
And that was all what day one was about. How fast can we see the biomarker change or the imaging change or the cognitive change or what have you? And, crossing fingers, maybe more quickly than we used to think we could. But, my suspicion is that, with all of the competing issues and everything else, if you can't see something happen in 3 to 5 years that would give you some signal, it's going to be really hard for us to find. It's just going to be very difficult to design the studies that will sort of have a longer purview than that. So, whatever the false active, they actually went out to 10 years to test all of the outcomes in as many people as they could. And, the fact that wasn't really completely satisfactory, because by that point you lost 2/3 or more of the cohort, was a problem. But it was like pretty much the best we've done in most of those sorts of things. There's some current studies ongoing, for example, following up on, they're still continuing to follow up on Sprint Mind. I think that would be very interesting, because you're still in that spot where I think we'll gain knowledge quickly enough. But for example, for Look Ahead. Look Ahead was the randomized trial of intensive lifestyle intervention to it fueled up because the endpoint was actually cardiovascular and basically myocardial infarction, which it had no effect, which is interesting. But even there, large trial, 9,000 people to start, trying to tease apart its effect on cognitive decline dementia, still not clear. And again, that was one of the more powerful and one of the most high touch trials we've done.
Beth, thinking about the biomarkers, so one of the challenges with the biomarkers is, as our technology improves, now we have a new measure, and now we have to wait for a while to see how well it works in the future. So that to me has been a real challenge in understanding the value of any of the biomarkers. Is like, I want to know if this predicts 20 years in the future, but you didn't measure it 20 years ago because the tool didn't exist. So are there opportunities for old data sets or old biosamples that we could really be reusing to evaluate some of those biomarkers?
Yeah, so I do think this is kind of the opportunity. So you can store these samples, there's some nuance in this, like time and tube can impact the quality of some of these proteins and stuff that's been shown for CSF and plasma. So it won't be perfect, but you can store these samples for a long time. And you can run them on assays as the assays become developed. So like ADNI is a good example of this, where they've done multiple iterations of running the CSF on different platforms as they've emerged. And the CSF analyses that have been recently released, even though it's on data that's 10 years old, is much better than the first round of released data. So I think that is something that could be leveraged. If there was some registry and we just banked the plasma, maybe we don't have the measures right now, but then we would be able to look at that snapshot, that baseline, in 10 years, if it was, affordable and cheap, and we knew what the combination of proteins, were that is most important. So I do think that is the possibility with plasma. And it's so easy. Relative to, I know when we're talking a lot about how we get these samples and the populations that contribute to these samples, but coming from the PET side, this seems so much easier than running a PET study. So it really seems like this is our compromise to collect plasma on as many people as possible, and then that can also inform the development of assays. If we link them to these risk factors that we're identifying, we can actually define the profiles, and then use that, that sort of insight to understand if interventions are actually working.
So in terms of representative, it is the case that HRS did do a venous blood study in 2016, and there's a pilot that's going to give us, it's a meeting to talk about. There's a call about that next week, exactly which AD biomarkers, so-called, we're going to be doing the 1,000 people who we also have in the harmonized cognitive assessment protocol. Now, the cool thing is that assuming that next year we really will be able to go back and retest and get more blood from these individuals and stuff, we will start to maybe know something if we choose the right things. And it's representative, but it's small. It's only 1,000 in this pilot study. Even if they ramped it up to all of HRS, all the blood we had to be like 9 or 10,000, which is a start. But if we sort of knew or could agree on the kind of a protocol we would be doing for these sorts of things, we could do it. We could do it. I mean, we would have to be costed out if we thought very carefully about. And some of the subgroup comparisons would be tough, and that's the other issue too. Yakil's not here today, but as she was pointing out, census-defined Hispanics are hardly a uniform group, and but HRS actually says they are, because that's all we divide by. But yeah.
Any of the old cardiovascular studies collect blood samples and bank them before, like earlier than that?
Well, Framingham has samples. There are a number of cohorts that have samples of some, right? Yes, Mesa, I think, has some too. And it's interesting because, of course, some of those studies have been sort of reactivated really quickly now to actually look at some of the pre and post COVID kinds of events that are happening. The C4R is this basically a cohort for all the cohorts that were basically HLBI cohorts plus regards, to sort of see whether or not they can detect any post-COVID changes of all kinds, including actually neurological. So there's going to be greater interest here, maybe we can take advantage of. But keeping enough people in these studies long enough and keeping them in the trials long enough is a challenge, and so we'll have to see.
I know we have to wrap up. Melinda, did you have a quick thing you were going to say?
No, I just said Eric also has samples. There's cohorts out there.
Eric, yeah.
So that could be really amazing. Okay.
But Eric, how many rounds of blood do they have in Eric left? It's like, I want to say 3. I could be wrong.
I mean, I'd have to go look because it's being slowly used, right? So,
yes, that's the problem. Yeah.
But I think visit 1's pretty well done, but I think there's still availability at the later visits, and they're still early enough processes, right?
Sure.
I think people are falling off, so maybe we should wrap up.
Yeah.
And so I'll say for my piece, thank you so much for all the panelists and all the really interesting discussion and questions. This topic is, Richard just put in the post, I believe this conference exceeded our planning expectations, and I agree. It's super interesting.
There you go. So one thing I could point out before we do all leave is that, as you know, there's a report being prepared from all of this, and the wonderful people at RLA are going to be working around the clock to generate that as quickly as possible. And when it gets closer to readiness, we are definitely going to be getting it back to all of the participants for their comments and edits on what we thought they were saying and everything. Actually, Derek or someone could any specifics on timing we can tell them now, or was this going to be just the next email blasts?
Hey, this is Caroline. We are looking at usually about a 30-day turnaround, so you'll see it in about a month.
Cool.
NIA will see it a little sooner.
Well, yeah, but we always just defer to you guys, so it doesn't matter. We just edit our own comments, make ourselves sound smarter, which is of course what you do too. It's all good. But thanks so much, and this has been a wonderful meeting. I think a lot of people learned a lot of things. We crushed it at about 160 participants yesterday. We had over 100 a couple points today. There'll be more people thinking of more ideas, and a lot of you were very generous giving out your email addresses in clear text. So in addition to all the spam you'll possibly get some scientific correspondence as well. And thanks very much. And last but not least, I just want to thank Maria for helping work so hard to help put some of this together when at various times we're a little bit stuck on things. And you might want to put this in the chat or not, Maria, but she's been actually live blogging, not live blogging, live tweeting some of the meeting, and had a tweet thread over the weekend that I think actually encouraged many people to register and attend this. And I'm really grateful because she's got a lot more followers than NIA BSR does. Although BSR, we're catching up, we got over 500, Maria's got 7,500. So, we know who's who, but thanks so much.
My pleasure. It's terrific. Take care, everyone. Bye-bye.
Thank you.
Have fun.
That's fun.